Sure, ma'am. We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect welcoming you all for today's webinar, Basic to Burden in Gynec Practice, organized by TNFOG and AMOGS, Emergency Obstetric Committee. It's my privilege to introduce the convener of today's webinar, Dr. Jairani Kamraj ma'am. Ma'am is currently the Joint Secretary of TNFOG, President of Oxy in 2023, Vice President of TAPISA, South Zone Coordinator of Foxy No to War Committee, Associate Secretary, World Association for Sexual Health, Advisory Council Member in World Association for Sexual Health, Member of Board of Studies in Dr. MGR Medical University.
Thank you.
Yeah. I welcome you, ma'am, and I hand the session to you.
Thank you, Sahiti. It gives me great pleasure and honor to welcome one and all for this webinar, a collaborative webinar between the TNFOG and the Emergency Obstetric Committee of AMOGS. I have the great pleasure and pride and honor to welcome the chief guest, Dr. Alka Madam, who will be joining with us, and the guest of honor, Dr. Kiran Kurtukoti sir, Dr. Ramani Devi Madam, Dr. Niraja Madam, for giving your precious time to be with us. We welcome you, Madam. And I also have the great pleasure and honor in welcoming the Dr. Sampat Kumari, the AMOGS office bearers, Dr. Kiran Kurtukoti sir, President, and Secretary Bipin Pandit sir, and my co-conveners, Dr. Monica and Dr. Aruna Suman, and my very dynamic convener, Dr. Sneha Buyer, for this webinar, which talks about the basics to burden in gynec practice. I welcome all the faculties, all the senior faculties, the speakers, and also all the other delegates who joined here for this webinar. We'll start this with a small inauguration, which starts always with a Tamil Thai Valthu. Sahiti, can I have Tamil Thai Valthu?
நீராறும் கடலுடுத்த நிலமடந்த கெழிதொழுகும் சீராறும் பதனமென திகழ்வழக கண்டமெனில் எக்களவும் அதில் சிறந்த திராவிடர்கள் திருநாடும் தக்க சிறு பிறை முதலும் தரித்தனரும் திலகமுமே திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனே தமிழனே உன் சீரிழமை திறம்பியந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
Always the prayer to the Lord always follows with a lightning of the lamp, which dispels the, which creates lights and knowledge for all our endeavors. Let's start with the lightning of the Kuttuvilakku. So we'll start with the formal inauguration. I have the great pleasure and honor to welcome Madam Dr. Alka Kriplani Madam, who is the chief guest for this webinar. Madam is a very well-known figure among all our Foxians, very senior personnel who has a lot of credentials on her professional associations. She being the President Foxy in 2016 and the President GSI, the Gynec Endocrine Society of India in 2011, and the President of the Delhi Gynecological Endoscopic Society between 2014 and 16, and the president of the Association of OBGYN of Delhi between 2013 and 14. Madam is the editor, Asian Journal of OBGYN Practice between 1999 and 2017, on editorial board for 9 journals, and she has been co-chair of the FIGO Menstrual Disorder Committee between 2016 and 18, and she has bagged more than 50 awards, a great being the Padma Shri for Distinguished Service in Medicine in President of India 2015, and she has got the BC Roy National Award for Eminent Medical Teacher in 2007, and had a honorary FRCOG given to her in 2007, a DMA Delhi Medical Association Award for the Medical Teachers Award, and DMA Shitikskas Ratan Award in 2014, and Vidya Bhushan Award of Gynecological Award in 2018, and the FIGO Award for the Female OBGYN in 2021, Economic Times Award, which is the most envious for the most inspiring gynecologist of North India. And she has done more than 1,000 guest lectures, orations more than 70, live workshops around 156, and many scientific publications reaching around 405, and organized conferences and workshops more than 130. And her field of interest, we know everything in Gynec. Madam is a walking encyclopedia, if we put forth in a simple way. And she's now the director and head of the Department of OBGYN and ART in the Paras Hospital, Gurugram, and ex-professor and HOD of All India Institute of Medical Sciences, Delhi. We welcome you, Madam, on behalf of TNFOG and the AMOGS Emergency Obstetric Committee. We welcome you, Madam. I think Madam is yet to join, I believe. So we'll move on to the. Let me introduce my convener, Dr. Sneha Boyer, who is a very great teaching person, more than 30 years of experience in the field of teaching, who has graduated from Pune, and she's got the Foxy President Appreciation Award of Public Awareness 2018, and also President Appreciation Award for her exemplary work in cancer in 2019. And she has been an organizing chairperson for the Critic Care in Nagpur 2018 and 19. And she has been the more than 300 talks in state and international and the national conferences. And she is the founder president of Vidarbha Isobab 2017 and president of the OIOGS 2007 and 18. And she is the member of AMOGS 2020.
Thank you, my dear. Thank
Over
you.
to Sneha to introduce the guest of honor.
Thank you. So, a very good evening to one and all. Thank you, Jairani, for having me here. Thank you, TNFOG. At the outset, I would like to welcome all the respected dignitaries, Madam Ramani Devi as the president, Dr. Sampath Kumari is the secretary, and of course, AMOGS president, Dr. Kiran Kurtakurti. I would like to invite and welcome all of you on behalf of AMOGS Emergency Obstetrics Committee and TNFOG. At the outset, I would like to introduce Dr. Kiran Kurtakurti, who is the chief guest, along with Dr. Alka Kripalani and Madam Ramani Devi. So I hope, Madam, good evening, Ramani Devi. I hope she has joined.
Madam joined. Madam joined.
Yeah. Okay.
I have joined.
So it's great to see you, Madam. And what to say about Madam? She's such an illustrious person with a highly decorated CV, and she's the president of TNFOG. She was the national vice president of FOXI and international advisory board member for Fertility Society of Bangladesh. I'm sure everybody knows you by endometriosis for the committee which she has headed, and lots of awards and accolades she has got. She's won 10 gold medals in UGPG and 5 FOXI awards.
Sega, I think that is enough. That is enough. Yeah. Okay.
So, Madam, over to you for your precious words. We are very happy to have you. Over to you, Madam.
Respected Kiran Kurtigodi, President of AMOGS, Dr. Sneha Boyer, and Dr. Jairani Kamraj, who are the conveners of this program. I think today's program is very much useful for the practicing gynecologists, because the topics chosen. IUI is the common basic infertility treatment that anybody can offer. And Dr. Chitra is going to give a talk on that. And following that, there will be a talk or by Dr. Meena Mahalingam regarding endometrial hyperplasia. Nowadays, after the increase in the incidence of polycystic ovarian disease, we find even endometrial, not only endometrial hyperplasia, but also endometrial carcinoma happening in young girls of 25 to 30. So I think her talk will be enlightening. And also we have a very interesting panel discussion. And I, on behalf of TNFOG, as the president of the same forum, I welcome all of you and I wish the today's webinar a grand success. And I also wish the Dr. Sneha Buyar for her, as she is contesting for the post of Vice President. Hope definitely this time she has to win. And I also wish Dr. Jairani Kamaraj, who is going to contest for the post of committee chairperson. And I wish them all a bright future and they should come out in beautiful colors. Thank you for the opportunity given. Thank you.
Thank you, madam. Thank you so much.
So
Now, yeah, over to you, Jaren.
So I'm so feeling blessed and so happy and honored to introduce Madam Dr. Neeraja Batla, who is the Padma Shri awardee, a prestigious Padma Shri award for her dedicated, passionate, and remarkable contribution which is a real milestone in our gynec oncology from India and also from our FOXY. This honor is a true testament of her unwavering commitment to the excellent service to the humanity. That's what I would like to tell you, madam. And your dedicated work in the gynec oncology is really an amazing, and we are very happy and honored to have you here, the Padma Shri awardee, to be here as our guest of honor for our webinar. So, madam is the Vice President FOXY of North Zone 2024, and she is the professor and former HOD of the Department of OBGYN from Jagat. And madam is affiliated as a faculty in New Delhi in AIMS. And her interest is no one can differ. That is the gynec oncology, madam's greatest pleasure. And had a passion. And she has so much of specialized in the gynec oncology and has undertaken numerous research products in this field, in particular on the cervical cancer prevention, especially in the low resource situations, in collaboration with many international agencies. And madam is known for her research on cancer, which she has taken over in the international level in Lyon, France, and also in the John Hopkins and also Bloomberg School. Madam is a great, passionate, and dedicated person in FOXY. We welcome you, madam, and we have the great pleasure to have you. Let's all hear your pearls of wisdom, madam.
Thank you so much for such a kind introduction, Dr. Jairani. Thank you so much for the invitation to be here today. It's been just such a wonderful and warm invitation coming from you, from Dr. Sneha, from Dr. Monica, everybody's personal invitation, and I value very much greatly. And it's such a pleasure to be here and see all my favorite people here on this screen. And so my congratulations really to the Tamil Nadu Federation as well as AMOGS for making this wonderful program today and combining such important things. So my greetings to the TNFOG office bearers, Dr. Ramani, Dr. Sampath, the AMOGS office bearers, Dr. Kiran, we've been meeting frequently, Dr. Bipin, and of course, I'm sure Madam will join soon. She is such a wonderful source of inspiration, Dr. Kriplani, and my fellow guests of honor as Dr. Kiran, and we heard from Dr. Ramani. And I agree with Dr. Ramani first at the outset. I must say that we wish our best wishes to Dr. Jairani and Dr. Sneha. They are such good, hardworking, academic people, and I think FOXY needs them, the country needs them, everybody needs these absolutely selfless and hardworking people to come forward. So my best wishes at the outset. And I was looking at the wonderful program and speakers that you have today, and it is really something that how much we are seeing the problems of adolescent health as well as the problems of infertility, which you have really put very practical points over here. And we see this routinely. As Dr. Ramani rightly said, even PCOS with cancer is becoming a reality. and we have solutions. That's the best part. And that is the awareness we have to give to people. They are so scared that you have announced that something may go into cancer, already become cancer. But they must understand the need for systematic approach, not to just go hopping from one place to other to confirm, is this really my diagnosis, trying to find someone who will say, no, this is not the diagnosis. Face the reality. Yes, you have got a problem, but we have solutions. We are here to stand by you. So I think very important for our gynecologists to refine their art of counseling so that they give the proper message. It is not unrealistic, because then they come back to fight with us saying, but you said everything is going to be fine. So while giving a realistic message with a note of caution, we must always give them hope that it is going to turn out fine, which is a real challenge nowadays. And we have this new committee now of violence against doctors, because we face the problem when patients don't understand what we are saying. And also the maternal collapse, which we are always dreading. This is the one thing obstetrician doesn't want to see, but from time to time you will see, where seconds matter, where teamwork matters, and very important to have your drills in place so that everybody reacts immediately. So all these things are the points where there is no time to go and consult even your up to date or book or anything, and you have to immediately know 1 2 3 what steps you will take. So I think really a program which is very nice, and we look forward to hearing it. So I will stop over here and wish you all very good luck and congratulations.
Thank you, madam. Thank you for your inspiration and thank you for your wishes. We from TNFOG, headed with by Sambat and Dr. Amni Devi, madam, and then AMOGS, we thank you so much for your time and talk. And that definitely, as you rightly said, we need a lot of awareness about such program to give them a knowledge about the cancer, that how we have to encourage them, how to make them get the treatment, and give them a positive approach, which is really mandatory that we all should know, ma'am. Thank you so much for your words and kindness. Your blessing, ma'am. And we now have the pleasure to introduce Dr. Monica Omarband, who is our co-convener of this webinar. She is a consultant of the OBGYN from the Mangalaya Nursing Home and Atharva Fertility Center, National Coordinator for the PAC Committee 23-25, Zonal Coordinator for AMOGS 24-26, and she's the committee chairperson of AMOGS. And over to you, Monica.
Thank you, ma'am. Thank you for your kind introduction. Thank you, Sneha ma'am and Ramni ma'am, for giving me an opportunity to coordinate this program. And it is my proud privilege to introduce none other than the President AMOGS himself. Sir has been the past chairperson of the MT committee, Foxy.
Monica,
yes, sir.
Monica, it's okay.
Yes,
it's okay. Thank
you for your blessing. Thank you.
Thank you so much. Thank you. Well, at the outset, warm greetings from AMOGS. And whenever it comes to Tamil Nadu Federation, I think I always look forward to the programs by TNFOG. For one thing, that I have spent good 6 months of my lifetime in Chennai with Kurian in Chetpat, and of course with Dr. Suresh in Mylapore. So at that time, I remember shuttling between these two centers. And at that time, Sarvana Bhavana was my lifeline. So I remember Chennai to the T. So thank you. So whenever TNFOG calls, I'm always there. So my respects to Dr. Ramni Devi, Dr. Nirja Batla, and of course to Madam Kriplani. And today's convener, there are 4 people who are gunning for the chairperson that I got to hear now. Sneha is there, Dr. Aruna, of course, Dr. Jairani and Monica. So best wishes from AMOGS to all of you. And, really look forward to all of you in various positions. My respects to Dr. Sampath also. Dr. Sampath, namaskar. And as
Sneha for Vice President, Kiran.
Yes. Sneha has put in a fantastic program, and apart from the IUI and the endometrial hyperplasia, I think the maternal collapse definitely is a lot more important topic. Is also an important topic, because Maharashtra has seen 3 maternal deaths in the last 15 days, which have shocked entire Maharashtra. And of course, violence against doctors that has shocked the city of Pune. And every day we are hearing about 15 to 20 minutes every day each and every channel is approaching us regarding what is the cause of death or what is the cause of violence, where everyone is going wrong or where the system is going wrong. So anyway, so good that Foxy has formed a committee of violence against doctors. So I hope, wish and pray that this committee really works for the upliftment or for the betterment of doctors. We are doing betterment for women, but for betterment of doctors, I think this committee is absolutely essential. And so look forward again to TNFOG. Thank you for again pairing with the AMOGS, and my best wishes to all of you, and of course Neha also. Thank you so much.
Thank you. Thank you.
Thank you.
May I introduce Dr. Aruna Suman, who is the co-convener of this webinar. She is the professor of OBGYN and HOD of Government Medical College, Telangana. She is the joint secretary of FOXY 2021 and the organizing secretary for ACOG Hyderabad 2024. And she's
Hello.
Yeah.
Yes, madam, welcome.
Yeah,
Madam,
Malika madam has joined.
Wow.
Ma'am, welcome,
How
ma'am,
are you,
welcome, ma'am.
Sneha?
Welcome, welcome. We
Welcome,
were
ma'am. Good
I
evening,
was
ma'am.
Namaskar, madam.
waiting
Sir,
for your
namaskar.
arrival.
We were waiting for you, ma'am. Sahiti, can I have
Thank
Madam
you.
CV? Let me introduce
Yes.
Madam.
Yes.
Yes, ma'am.
Welcome, Madam CV.
Yes, ma'am.
Madam
Just a
doesn't need
second.
any introduction, though we have, the CV, which we have to actually read formally. So,
No, no. I don't need any CV, Baba.
Ma'am, no, ma'am. We just want to welcome you, ma'am. Ma'am is I would like to say that Madam is a walking encyclopedia who had a lot of professional associations as a president of FOXY in 2016, president of Gynecological Endocrine Society of India in 2011, and she's still continuing in that as a president. And Madam is the president of the Delhi Gynecological Endoscopic Society between 2014 and 16, and she's the president of the Association of OBGYN of Delhi between 2013 and 14. Madam has editorial board of more than 9 journals, and she has been the co-chair of the FIGO Menstrual Disorder Committee between 2016 and 18. And she has bagged more than 50 awards, the best being the very prestigious Padma Shri for her distinguished service in the medicine, the President of India, 2015, and BC Roy National Award for Eminent Medical Teacher in 2007, and Honorary FRCOG from London in 2007. And the Delhi Medical Association has given her,
Okay.
Madam, it is our pride and honor to tell everything, the greatness that will be inspirational for all the listeners here, ma'am. And the Vidya Vibhushan Award, ICOG in 2021, and CNBC Award, the Center of Excellence of Gynecology in 2018, and the FIGO Award for the Female OBGYN in 2021, and Economics Time for the most inspiring gynecologist of North India. And she has done more than 1,000 guest lectures, more than 70 orations, more than 150 live workshops, and more than 500 scientific publications. And she has organized many workshops. And of course, Madam, you are the set example for a walking Gynec encyclopedia. We welcome you, ma'am. Our TNFOG, headed by our President Ramani Madam and Secretary Sampath, and AMOGS, Emergency Obstetric Committee, headed by Kiran Sir and Pibin Sir. We welcome you, ma'am, to be the chief guest for this, and let's all have your blessings and pearls of wisdom, ma'am.
Thank you so much, Dr. Jayarani, Dr. Sneha, and my dearest friend Ramani and Sampath Kumari, whom they have worked so well in Foxy that Ramani everybody looks up to. She is also such a great academician, and I'm so happy that she is now chairing there. I always tell her, Ramani, you must come first president. You will change the academics in Foxy. But she is such a hardcore worker, and she is so shy. But I really admire her so much. And Jayarani, thank you so much for your kind words. This webinar, I really don't know how many topics, but what I know is you girls from Chennai and South and Trichy are doing great work. There were times when, I'm talking of years back when South people were not so active. Now you people are more active than other And secondly, whatever activity you do, I see lovely attendance of people who sincerely want to learn, be it physical conference and be it webinar. So I really appreciate you for your this endeavor, and I know the topics are very wide variety of topics are there today, but I think for general gynecologists it's very important. They are interested in infertility and they are more interested in obstetrics, and your topics are very apt for the learning. Thank you for your kind words without taking much time. I really wish you all the best and very happy learning to everybody.
Thank
Thank
you,
you.
madam. Thank you, madam. As you
Thank
rightly
you,
said,
madam. Thank you so
presently
much.
we have 128 participants, ma'am.
Oh, Dr. Ramani is
Madam,
there. Wow.
Alka madam, good evening. Good evening.
I am a big fan of Ramani because of her work. Yeah,
Madam, very nice to see you, madam.
thank you.
Nice to see you. Okay.
And everybody should know Ramani did PhD at this age and she is always a student, true academician.
Thank you, madam. Thank you.
Thank you so much, ma'am, for your time and your inspiration, ma'am. Thank you, ma'am.
Thank you.
Over to you, Aruna. Over to you, Aruna.
Yeah, thank you. Thank you, Dr. Jairani. Can I have the introductions, please? Thank you for the opportunity. And thank you, Ramani ma'am, Sampat Kumari ma'am, and the chief guest, Alka Kriplani ma'am, and Mr. Kiran Katkoti sir. It's my privilege to share the digital platform with you. And thank you, Nirja Batla ma'am, Ramani ma'am, for this opportunity. May I introduce, can I have the CV?
Yeah, Aruna, you start with the scientific section. No problem. You start nothing.
Ma'am, please let me have the privilege of introducing you because I worked in your committee as a member.
You
Please.
start with scientific session. Best wishes
Yes.
for all
Okay,
of you on
no
the webinar.
problem.
Yes.
Just
Yes.
your precious words, madam. No introduction. Over to you, madam.
Sambat, say a few words, Sambat.
Yes, really, we are happy to have the TNFOG program with AMOGS under the leadership of Kiran sir and Bipin Pandit and our president, Dr. Ramani Devi. And as everyone was telling, 4 of you are contesting now. Jairani, Monica, Sneha and Aruna. I wish this time all of you will win.
Thank
and
you,
the best wishes for this webinar. And we will start with the scientific session. Definitely you people are doing a wonderful work. Definitely this year is for you. Thank you.
Thank you, madam.
And thanks to Alka madam. In her busy schedule, she has joined. Thank you. And Neeraj.
Yes, thank you so much, all the respected dignitaries for joining. And thank you for your precious words and blessings. With the God's blessings and of course the esteemed guest and chief guest blessings, I think we should move ahead with the academic session. And over to you, Jairani, once again.
Yeah, I have the great pleasure and honor to welcome and introduce our senior gynecologist from Erode, Dr. E.S. Usha, who has more than 30 years of experience at the Lotus Multispeciality Hospital. She is the past president of Erode OBGYN Society, member of FOXI and ISUOG, and she is the faculty for the National Fetal Medicine and OBGYN Conference and Workshop. And she is a Rotarian volunteer in performing high-risk gynec surgeries in Nigeria every year. We welcome you, Madam Dr. Usha. And I have the great pleasure and honor to welcome my good friend, Dr. Mary Ann, who is a dynamic person from South, that's from the Nagargoil, who was the president of Nagargoil OBGYN Society between 2016 and 18. And she's the present president of the Rotary Club. And she's a women doctors wing chairperson of the South Zone. And she has so many accolades. The national coordinator of the Self Motherhood Committee in 2021. And she is the organizing chairperson of the NOXCON between 2016, 17, 18. And she has been organizing many awareness programs in schools and colleges and almost many adolescent programs she has done. We welcome you, Dr. Mary Ann. And I have the great pleasure and honor to welcome Dr. Sushani Bopi, Madam, from she's from the PUSV OBGYN Society, who is the director of the Varad Netralaya and Maternity Hospital, PUSAD district. And she's the president of the PUSV between 2025 and 26. We welcome you, Suhasini, madam. And I have the great pleasure and honor to welcome Dr. Deepali Shukla, who is the director of the Shukla Test Baby Center from Akola, who is the member of IFS and EZARD, and faculty in state and very national, very many conferences. And she is the organizing secretary of the Akola Hysteroscopy Workshop. And she's the organizing chairman of the Ferticon 2024. And she's the president of Akola OBGYN Society in 24 and 25. We welcome you, madam. Over to the chairpersons for taking over the first session, scientific session.
Ma'am, can I share the slides, ma'am?
Yeah, please.
They're asked to request.
Usha madam, are you there? Mary Ann, I saw her. Suhasini madam is there?
I will introduce Dr. Jairani.
Yeah, please.
Okay. It's my, I feel wonderful and happy to introduce dear friend, Chitra Tyagaraju. She's a fellowship in reproductive medicine and minimal access surgery, certificate course in advanced research methodology, JIPMA. His affiliations, Jawaharlal Institute of Postgraduate Medical Education and Research and Pondicherry, India. Awards are Dr. Purnima Nadkarni Award, ISA 2020, and Asha Rao Award 2017.
Madam, thanks, madam. Thanks. I think I really want to thank the AMOGS team and the TNFOG team for giving me the opportunity to talk on my favorite topic, the tips and tricks for success of IUI. And on this platform, I'm really privileged to have all my stalwarts and mentors, Shweta Ramani madam and Sampath Kumari madam, Jairani ma'am, Sneha ma'am, Aruna ma'am, who really guided me and supported me in all my academic events. Thank you so much, and I'm privileged to be talking in front of you. Can I share the slides, ma'am?
Yes, ma'am.
Can you see the slides, please?
Yes, ma'am.
Yeah. So today my topic is tips and tricks for the success of IUI. So let me start with a case scenario. If, when a patient comes to you, like with 5 years of infertility, with the regular cycles, and she has already undergone 6 cycles of ovulation induction, you don't find anything on examination, abnormal pathology on examination, our AMH is 2.3, and semen analysis shows 15,036 motility. Tubes are patent. So next thing, what you will think, first thing you will think, okay, let me go the empirical, like you have a patient has a failed ovulation induction. Next will be either you have to do to find out the cause, either you go histolaparoscopy if you find any pathology. If no pathology, you go for the IUI. So when you decide for the IUI, you should be having prediction of what may be the success of IUI. You have to consider a lot of things. First, you need to counsel the patient. Doesn't mean that you're doing IUI she'll give a lot of success. So you have to tell the success of IUI versus IVF. So give a right to decision. The success in IUI is so much, IVF, whether she wants to go for IUI directly for the IVF. And you should think whether this IUI will have a potential benefit, whether it is more or it is less, because you need to avoid the economic, emotional, psychological trauma and doing unnecessary repeated IUI cycles if 1 or 2 cycles fails. Most important in this patient is to save the time, because which is very crucial in our infertility management. And when the patient wants to have a direct the couple, when you find that this patient is not fit for IUI, it's better you shift the patient for the effective techniques, especially patient with advanced age. So when you come to the appropriate patient selection, this forms a very important factor which determines the success of IUI program. And you have to always think first work of the patient, and you find out whether this intervention will be really going to be useful or not. The main basis of treatment, we should know that we are improving the quality and quantity of the gametes which should be available for fertilization, and so to bring them closer by bypassing the factors which depends on the deposition of sperms in the vagina and transport the cervical canal into the uterus. So for that, we need to know the indications of the IUI. For this thing involves a complete workup of the patient and come to the diagnosis. So once the diagnosis is established, you will come to know whether this patient is fit for IUI or not. So an important, once you tell the patient is for IUI, you need to counsel the patient on the success rates, any other options available, and the risk involved in IUI. So these are the various indication. I think most of them, everyone knows what are the indication, but you need to know a correct indication increases the chances of IUI. So the most common indication what we are doing is unexplained infertility or mild maid factor infertility. So when you work up the patient, you should also know what are the contraindications. You should plan whether to give trial or not to give trial. So that you have a relative and absolute contraindication, and most important is the tubal pathology, followed by if the patient is having severe OATS or any infections, or patient have this cervical bleeding or unexplained genetical bleeding, or patient have any pelvic surgery which might alter the anatomy of the uterus or the tubo-ovarian pathology, which might interfere with the movement of the sperms. So when you have to success. You know the success reported per treatment cycle. The pregnancy rate depends on the per treatment cycle. It ranges from 8 to 22%. So, and our aim is to achieve 22% success rate is a primary care for our fertility enhancement. So we have the following presentation where you need to keep and track of how to improve the success. First, we should catch the patient young, so that studies have shown that the pregnancy rate decreases as the patient age advances. So it is 13.7% if the patient is less than 40 years and decreases to 4.5% as the age advances. And we should know no pregnancy occurs after the age of 42 years. Even the AMH is good, other parameters are fine. We should never try IUI for a patient who are more than 42 years. This table shows the pregnancy rate, and you see less than 30 years, it is 13%, 30 to 34 years decreases to 10 to 12%, 35 to 8%, and at 40 it becomes as low as 1.6%. So men, it doesn't mean, though we know that the aging process men is slower than the women, it has shown that there will be poor prognosis as the age of the men occurs more than 35 years, because it leads, it's primarily because of the non-disjunction of the spermatozoa. They produce sperm which has they are very incapable traveling the normal linear path, so thus covering the less forward distance per unit time. So in these patients, even though considering the age of the woman, you should also consider the age of the men. And next comes the duration of infertility. Studies again have shown that the lesser the duration of infertility, the high chances of success of IUI. So less than 6 years, 14%, and more than 6 years is 6.1%. So you should never delay the IUI in these patients. When you take the etiology, the most common etiology, the success of it depends on the two important factors, that is unexplained infertility and mild maid factor infertility, which have success rate of 18 to 22%. So it is very important, and least is in patients with endometriosis. So when you're considering this patient, you have to see the success. Okay, these patients are the one which might be having sex, so let us try in this. If you have a mild endometriosis, yes, you can have a good success, but you should be very careful when you're doing for moderate to severe endometriosis. Next, coming to the drugs. When you know where you can use clomiphene, you can do letrozole, you can use gonadotropins, you can do sequential gonadotropins. But before you do, you should know the type of the patient and what is I think I'm going to tell what are the dose, the age, the AMH of the patient with the previous treatment, what she has taken, the drugs. This all should be considered. The success of each medication what you're giving, you should be well aware. Like letrozole is clomiphene 4 to 9%, and with the gonadotropins it goes as 8 to 10%. If you're doing for a patient with annuity infertility, that PCOS, the success with gonadotropins increases as high to 20 to 26%. With the sequential gonadotropins, we have the pregnancy rate with IUI decrease from 12 to 18%. So whatever the drugs we're using, we have to make sure that at least we aim to induce at least 2 to 4 follicles, which is 18 to 20 mm. For oral virgins, 20 to 21 mm should be dominant follicle. And you have to try with the sequentially. First, you can go with the letrozole, then you can go with the sequential, then you can go for the gonadotropins. I'll tell you the role of antagonists and agonists, whether it's important or not. As I already mentioned, you should, when you tell the dose, you should know the BMI, reserve, age, cause of infertility, and what are the dose used in the previous cycle. So what is the number of follicles which is shown to have a good success? Having a minimum, one studies have shown that having a minimum of 3 dominant follicles, the chances of pregnancy is 16.3%. But whatever the meta-analysis, it has shown that one stimulated follicle should be the goal, but whereas 2 follicles may be accepted after careful patient counseling. So, but we need to not more than 3 dominant follicles should be there, or you need to can cycle. So pregnancy rate have found to be more with a superovulation, that is like you can do sequential or you can go gonadotrophies. Monofollicular growth, you can go on increasing the number of follicle, which increases the pregnancy rate of 8%. And multiple follicular growth, anything more than that, increases the chances of multiple pregnancy and also the OHSS. So this is one study which has used as this as Cochrane review, which has shown that when CC with letrozole was used, they did not have any significant differences. But when gonadotropins with CC was used, it had a higher pregnancy with gonadotropins, but with the different types, whether to use HMG, urinary FSH, or recombinant FSH, did not find any significant differences except for the increase in the cost and chance of multiple pregnancy was more in these patients. So regarding then coming to the how to prevent the LS surge in IVF cycles. Sometimes the LS surges we thought will occur only in IVF cycles, but studies have shown that 25 to 30% of the patients who undergo IVF cycles can also have premature LS surge. So administration of GH antagonists almost completely abolishes this luteinization, but it has shown that it doesn't substantially improve the pregnancy rate. So one of the consequences is the poor quality of growing follicle. So other benefits, it might control the LS surge, it can cause a proper synchronization with single IUI, and can be whenever I'm in a weekend, we don't have to do IUI, it can be helped to tide over the weekend. So we have antagonists and agonists to downregulate and to prevent the LS surge. I've just taken the 2 studies which have shown that one study have shown that giving a flexible protocol of 0.25 mg of cetrolix at day 6 have shown to suppress the premature LS surge in patient with letrozole and gonadotropins. But however, the incidence premature surge remains too high and modification will be necessary before the application. The other study have shown that though there is an increase in the pregnancy rate in this patient, the live birth rate are not significantly different in patient who received gonadotropin GNH antagonist versus placebo group. And one review, Cochrane review, has shown that when they're using the Soven stimulation protocols, the adding of GnRH agonists did not improve the pregnancy rate, although it resulted in significant higher multiple pregnancy rate. And the data from the 3 studies have shown that there's no convincing evidence of adding GnRH antagonists to the gonadotropins. So the role is the agonist doesn't seem to have any role in IUI programs, just it increases the cost, but my chance increases the chance of multiple pregnancy. Antagonist, whether to use or not, still a large studies, large randomized control trials should be done to get into the practice. The role of Dopplers. Yes, nowadays I think so. Dopplers have shown to increase the chances to know when the trigger should be given, when the IUI should be done. It has shown that when the unexplained infertility patients have high impedance blood flow in spiral arteries, and concluded that the endometrial perfusion may have an important contribution to the etiopathogenesis of unexplained infertility. So when they connect the studies in patient who conceived without the patient who did not conceive, they found in patient who conceived, they significantly lower uterine artery PI, higher frequency of positive diastolic flow, and lower PI of the intraovarian arteries. And one study which has shown that doing the endometrial pattern and seeing the perifollicular flow Doppler changes, they've shown that color Doppler flow study of the uterus over at the time of trigger may be one of the good predictor for successful IUI outcome. I think Dr. Sonal Panchal have did a large study involving more than 1,000 patients, and she has told PSC more than 10 and RI less than 1 at the time of the trigger increases the chance of the IUI. Then coming to the sperm, the parameters, it has shown from the intervals of semen collection to semen wash should do doing IUI, or semen collection IUI, the way shorter in successful in then patients in the unsuccessful IUI cycles. In a patient who became pregnant, they found overall from semen collection to the IUI, the period was less than 90 minutes compared to the patient unsuccessful, where the period of from the collection to IUI was more 56. So our aim is that we have to try to the IUI less than 90 minutes from the time of collection to the insemination. So which means that shorter the duration between collection and IUI, better would be the success rate. Then coming to the semen preparation techniques, those various studies, Cochrane have shown that swim up and density gradient is better. It also depends upon the indication, but they do not find any difference in the various semen preparation used for the IUI, whether it is swim up gradient or wash centrifugation. When you're taking the parameters, it has shown that a sperm count of 5 to 10 million and motility of more than 40%, morphology more than 4% had a better success rate of IUI than compared to the patient who had lesser count, lesser motility and morphology less than 4%. Then once you stimulated, when you do the semen preparation, now you have to plan when to give the trigger. When you plan the IUF trigger, whether it is 24 hours, 36 hours, or you wait for the document of ovulation or not. So when you plan the trigger, we know almost everyone are going to give the SCG trigger. I recommend SCG is not necessary in this patient. Whether you have to give urinary SCG 5,000 or 10,000. When they compared with that of the genus agonist, they found that the pregnancy rate was more in patients with the SCG trigger than agonist trigger, but the miscarriage rate was less in the genus agonist trigger. And other thing which was shown that whether when you give a trigger should we monitor the LH search. The combination of the monitoring that LH kit along with that of the SCG trigger amplifies the benefit of the increased chances of pregnancy. So you can do the LH kit monitoring. When the search double line occurs, you can give the SCG trigger, then you can do the IUI 36 hours later. Then coming to the timing, when should do the IUI? We should do before ovulation or confirm the ovulation. How many times IUI should be done? Whether should we do single, double? Should we tell the patient to have time coitus after the IUI? So timing of the IUI, it is very, I think we have what are the current available evidence is there. It shows it should be followed from 24 to 36 hours after SCG injection. Some amount of timing can be performed along with the LS search, and a single well-timed IUI after the confirmation ovulation is always better. Double should only be advised when it's proven effective, especially in cases of male factor infertility, because doing a double I increases the cost and psychological burden to the patient. So when we found, when I saw the one study which has shown that the timing of the IUI this is shown that single IUI timed post ovulation gives a better clinical pregnancy rate when compared to single pre-ovulation IUI, especially for non-male factor infertility. Whereas for male factor infertility, pre-ovulation and after ovulation, double IUI gives a better pregnancy rate than with a single IUI. And the timing, when to do the IUI, whether should we do a 12 hours, 24, 36 hours. So when in one study they did a 24, 36 hours, they found that doing an IUI 36 hours had a better pregnancy rate than doing after 24 hours. And one more, the study they divided into 12 hours, 24, 34 hours after administration. They found again the pregnancy rate was better after 34 hours after the IUI. So after the SCG trigger. So sometimes even you wait for 34 hours, ovulation is not occurred and you have to wait, what will be happen? Should we postpone the IUI till the follicle rupture? Yes. Clinical pregnancy rate was found to be 24% when a follicle rupture was evident by transvaginal ultrasound, and it was 8.8% when a follicle rupture was not evident. So plan IUI after observation follicle rupture. This may yield a higher pregnancy rate. Then coming to single versus double IUI, two insemination, the 24 to 31st can be done. The rationale for this is to create an opportunity for long fertilization period, as a follicle may can rupture over wide interval like 22 to 47 hours. So the disadvantage can be it increases the cost. Again, I told you, it can increase the cost, psychological burden to waiting for the again coming, traveling, all this can have psychological burden on the couple. So here one single randomized control was done, single versus double IUI. They did not find any differences, though the clinical pregnancy rate was more in double IUI compared to the single IUI. They do not find any differences in live birth rate between the single and double IUI. So other studies which I've quoted also did not find any much differences, and they found much more differences in the patient with male factor infertility. Catheter. Coming to catheter, whether should we use a soft catheter or a firm IUI catheter? One review, that is Cochrane review, it has shown where they have ignored more than 12 studies, one on the live birth rate, clinical pregnancy rate, miscarriage rate. They did not find any evidence of significant effect on the differences between the choice of catheter, and they did not come to a specific conclusion like which catheter is better, the firm catheter or the soft catheter is better. And they have to, they advocated like further randomized studies should be done, power studies, and also look into the miscarriage rate and discomfort when using this catheter. The volume also matters when you're doing for this patient. You know, the ranges of volume can even go from the 0.2 to 1 ml, and usually volume equal to greater of 0.4 ml reaches the uterus and their tubes. And this variation, the variation of volume insertion depends on the capacity and distance of the uterine cavity. So one study have shown that two groups, one group has taken around 0.45 ml, other group 3 ml. They shown that though the pregnancy rate in the patient who had 0.5 ml was 14%, and in pregnancy rate in patient had 3 ml for 15%. This result did not demonstrate any the superiority of one method over the other method. It's as good as using 0.5 ml. The more the volume is used, it might initiate the uterine contraction and might also cause the reversion of this semen preparations. Then coming to the other thing, the speed, the technique, how to inject and how to remove the catheter. So one study which was done in recent 2022 have shown that a slow release insemination and a patient-centered approach, they found that the intentional application of modified slow release for a period of slowly 1 minute have shown to increase the clinical pregnancy rate after IUI with a homologous semen. So, but also advocated that future studies should be investigated whether this slow release patient-centered measures or a combination of both are responsible for this improvement, whether it's because of patient characteristics or because of slow release patient had a better pregnancy rate. And again, insertion, the technique. So one study have shown that you have to take the volume of air into the syringe, insulin syringe, before you inject it. They can, without the volume of air, 0.1 ml or 0.5 ml, they found that the chances of the volume array within the catheter had a significant relation with the success of IUI, and they found that 1 ml of air before you take the semen sample had a better pregnancy rate compared to no or 0.5 ml. And the speed and technique, does it matter? Yes. When you're putting the catheter, see that it doesn't touch the walls of the vagina, and it should be gently introduced into the uterus without any force and without any damaging the endometrium. If you find there is a stiffer or cervical stenosis, you can use a stiffer catheter and never hold the Alice for the anterior lip of the cervix. You can hold the Alice at the junction of cervical vaginal junction, which will be less painful for the patient. And when you hold the Alice, you should not lock. Once you negotiated the internos, you have to release the Alice forceps. Luteal phase support, yes, you have a various in the market like macrocytostan, digosterone, and different routes. And whatever the studies have shown that luteal phase, yes, is very important whenever you use a gonadotrophies. Either you can use a 200 microns vaginal progesterone, or you can use a dihydrogesterone orally. Nowadays, even quinone gel 9% used vaginally after the IUI have shown to have a good success rate. Then coming to the endometrial scratching, we know that endometrial scratching patient recurrent implantation failure increases the success rate, but many of the assays did not prove that. And they have shown that any endometrial scratching or taking a just biopsy in the probability phase of cycle, day 8 to day 9 of the cycle, have shown to have a better pregnancy rate. We also at JIPA Institute, we did an endometrial scratching at the day 8 and 9 cycle of the same cycle of the IUI, and we found the pregnancy rate in a patient who underwent endometrial scratching was 22%, compared to the patient who did not do endometrial scratching was around 10%. So, but we couldn't get into generalized into population because of sample size are small. So next, coming to clinical decision, when about the IUI and IVF, when you should refer the patient, shift from the IUI to the IVF. As I've told you, you have to try all the origins and gonadotropins before you know the success is not there, then you can subject. So maximum of 3 to 5 cycles should be done. When it is found to be unsuccessful, yes, you should counsel the patient for the IUI. Before you do that, you have to find out that any other causes there which are contraindicated. After 2 cycles, you should know, you should re-evaluate the patient and find out any contraindication is there or not, which would have missed it early, because sometimes you can start empirically. So assess, if you feel that she's not fit, go for the IVF. If you feel if she's fit, then you can continue the IUI cycles. This is a table showing that the IUI and IVF success. You have seen the blue color and the light green color. The success of IVF is better when the patient is 35 years. The overall success of IUI, we know it is around 18 to 22%, but it's a well-established lab, or it is around 11 to 12%. So it's better, if at all you counsel the patient, the success of IVF is better in patients who are less than 40 years. So you have to do the pros and cons, whether you to do IUI or IVF. So if you're planning for years, see that the success is there or not in this patient. So the treatment, number of treatment cycles, as you know, third cycle, first 2 cycles is a better, you can assess. A third and fourth cycle, the success of your decreases. So if the patient fails in first 2 cycles, reassess and reconsider whether should go for third cycle or subject the patients for IVF. So what factors which define the success of that IUI? According to one study, it has shown that engaged women with cervical annuity infertility with total amount sperm count more than 5 million, and IDA stimulation which recruit at least 2 dominant follicles measuring more than 16 with a concentration of 500 picogram per ml on the day of SCG, and it is success important when they use soft catheter. So one review which has shown that when you're in a patient when advanced maternal age and paternal age has a negative impact on the pregnancy rate. Though paternal obesity contributes to infertility, the elevated BMI might not affect the pregnancy, but it will really impact the excess of gonadotrophin requirements. And they have told you can use letrozole or combination of letrozole with gonadotrophins, and the especially indicated are the unexplained infertility and mild maternal infertility, but the success decreases with the tubal factor and stage 3-4 endometriosis. And most pregnancies occur within the first 4 cycles, so after which in vitro fertilization should be considered. So you should consider all these factors before you counsel the patients for the IUI. So take home message, first important is very proper patient selection, the indication, the age, motor sperm count, appropriate stimulation protocol, good semen preparation lab tech work, meticulous procedure, luteal phase support, and if at all patient has to, with every parameter is normal, try to do endometrial scratching. If a 2 failed IUI cycles, then try 3rd and 4th in endometrial scratching. Regarding the ovarian stimulation, you can use gonadotrophins before you subject the patients for IVF, and addition of androgens can be done if you are marginally to possibly better timing of IUI, and timing of IUI needs to be revised. You have to, if you are not able to do time it after ovulation, you don't have time, that you cannot wait. A single count of 40 to 41 hours after SCG trigger is more than enough for you to, without doing the ultrasound, you can do the IUI, and see that post semen count more than 5 million should be there, which is a minimum requirement for doing the IUI. And any method of semen permission can be equally efficacious. So this is a thing. The goal, it should be 2 dominant follicles, and morphin should be more than 4% count. I have told you 5 million, total 30%. Combination always COH with IUI should be done. Double IUI, yes, it is good accuracy, especially in patient with male factor infertility. And trigger should be done at interval should be less than 90 minutes, and you can give IUI after 36 hours, and at least 10 to 15 embolization is necessary after the IUI procedures. Thank you so much. Thank you for the opportunity.
Wonderful lecture, Dr. Chitra.
Thank you, ma'am.
You have explained very nicely on tips and tricks on increasing success of IUI. And you explained you should know the indication, correct indication will increase the chance of success rate. That is very true. And you should know the contraindications too. And one important point you have highlighted, that age of main is also important for success of IUI. We can use Doppler to increase the chances of success of IUI. One question, madam, that in donor insemination IUI, do you go with only clomiphene citrate or letrozole, or you add gonadotrophins to increase the success?
Ma'am, all IUS, we usually go letrozole with gonadotrophins. We don't want to waste time. So that letrozole, it will cut down the cost of the patient, and patient will have a better ovulation rate. So we, almost all patients, even with donor, we go with the sequential gonadotrophins.
Okay. And what about USG guided IUI?
Yeah, we won't do usually USG guided IUI, but if at all we have found that the patient we have a difficulty like anteversion or retroversion of the uterus, in that we'll take a guide of the ultrasound when you're doing the IUI, or as most of the time it will be very simple. And if you find that a patient is having a difficulty like a stenosis, so we'll try to do the uterine sound. If it is not there, we will try to do intracervical insemination, and we'll document that it, in spite of intrauterine sound, it can be not be done. So next cycle we'll do the hysteroscopy. We'll find out why is the cervical stenosis. If you have any fibrosis, we usually cut, dilate it, and next cycle we'll remember, try to do on day 8 or day 9 like endometrial scratching, so that it will be easy for insertion when you do the IUI.
Right, madam. And your take on endometrial thickness before IUI, if you are not explained on endometrial thickness, should we consider
yeah, madam. Actually, I forgot to put that slide. Actually, studies have shown that if the endometrial thickness is more than 7 mm, okay, it's good, you can do IUI. And the role of estrogen should be add or not, and there is no role of adding estrogen, because when you're going to see just per se, if you cannot see the dominant follicle, you can wait until it is more than 7 mm. Even the dominant follicle is 18, 19, do not have to give the trigger. You can wait even up to 20. 21. So only when endometrial thickness is more than 7 mm, you can give the trigger.
Okay, right.
So ideally, Chitra, will always trigger for an IUI cycles between 20 only. We never
yes,
go like an IVF. In IVF, when we have 18, we trigger, but in IUI, it is always better you go up to 20, 21. That will give you a still more mature follicles and mature proper endometrium.
Yeah. Yes, ma'am. We usually go. Yeah, ma'am.
So I think we'll go to the next topic.
Thank you, ma'am.
Thank you.
Madam, introduce Deepali, madam. You just introduced speaker Meena.
Yeah.
Madam,
Next speaker is Dr. Meena Mahalingam. She is MD DGO DNB and she has taken special training in urogynecology, microsurgery and endoscopy. And she is instructor in basic newborn care and resuscitation program. She has vast
thank
clinical
you.
experience of 23 years and she is master trainer of AMONC and faculty and
Thank
organizing.
you.
Yeah, we welcome Dr. Meena.
Thank you, Deepali, madam.
Yeah.
Thank you, TNFOG team and Jairani madam, Sampath ma'am, Ramani ma'am for having given this opportunity to talk on endometrial hyperplasia approach and management through different ages, like from adolescent to perimenopause and menopause. As we all know, I would be just briefing about what endometrial hyperplasia means and then take through epidemiology, little bit about risk factors so that how we manage will be dealt better, and the latest classification, the pathogenesis, clinical presentation, investigation and the management. The endometrial hyperplasia is defined as irregular proliferation of the endometrial glands with an increased incidence in the gland to stroma ratio when compared with the proliferative endometrium. Next slide. So as we all know, we do have this endometrial hyperplasia being transformed into endometrial carcinoma, that being 25% in adenomatous and 50% in atypical and 100% when there is a carcinoma in situ. Epidemiology, the endometrial cancer is the most common gynecological malignancy in the Western world and endometrial hyperplasia is its precursor. Globally, there were 382,000 cases of endometrial cancer and deaths due to that range from 89,929 in the year 2018. In India, the statistics states that 13,328 cases and 5,000 deaths in the same year. The age standardized incidence is around 2.3 per 100,000 women, which is quite high. The incidence of endometrial cancer is increasing globally due to increase in the life expectancy of our women, use of postmenopausal hormone replacement therapy, and increase in the obesity in our population. It is thought as predominantly a disease of the elderly postmenopausal women. The mean age of diagnosis is 63 years, and majority of the cases occur between 55 and 65 years. The incidence of endometrial hyperplasia is estimated to be at least 3 times higher than endometrial cancer, and if left untreated, it can progress to cancer. As Ramani ma'am has told, it could be a malignancy even in younger age women. So we need to think about it and then screen for endometrial hyperplasia. We need to know about the risk factors going into the endometrial hyperplasia, the nulliparity, late menopause, obesity, chronic anovulation, polycystic ovarian syndrome, estrogen secreting tumor of the ovary, exogenous unopposed estrogen therapy like hormone replacement therapy, or endogenous secretion of estrogen, tamoxifen therapy, hereditary factors like Lynch syndrome, where there could be a carcinoma, colon, endometrium, and ovarian cancer, and protective factors like multiparity, normal weight, combined oral contraceptive pills, progesterone therapy, menopause at around age of 49 years. This was the classification which was followed in um, earlier years, like simple hyperplasia and complex hyperplasia, which is basically based on the architectural pattern, and atypia based on the nuclear features. And there was a system, that is endometrial intraepithelial system, which has been replaced recently. Previously, we used to remember this number as 13829, that is simple hyperplasia without atypia 1, and complex hyperplasia being without atypia as 3% progressing to cancer, simple cystic with atypia progressing 8% to cancer, and complex adenomatous hyperplasia with atypia progressing to 29. This we used to really read during our postgraduate days. But now in 2014, WHO has classified this hyperplasia as 2 grades based on only the cytological atypia as hyperplasia without atypia and atypical hyperplasia. The incidence of progressing to cancer is around 1 to 3% in without atypia and 30% in atypical hyperplasia. As we need to know, there is unopposed estrogen stimulation on the endometrium, which could be due to increased production from the ovaries, adrenal, or due to obesity, and decreased degradation mainly because of impaired liver function and increased estrogen intake, as in the form of menopausal HRT, which really leads to relative excess of estrogen in the body, leading to endometrial hyperplasia progressing to endometrial cancer. About endometrial intraepithelial neoplasia classification, 2017 by the International Group of Gynecological Pathologists and endorsed by the American College of OG Society, benign endometrial hyperplasia includes about benign changes without atypia, which progress to 0.9% endometrial cancer, and endometrial intraepithelial neoplasia, representing the pre-malignant changes, progressing to 19% cases of endometrial cancer. Now, as we know, we need to know the symptoms to deal with the management. In women, throughout from adolescent to pre-menopause, the women can have either a heavy excessive bleeding during the period or periods that last for several days, around 7+ days, or inconsistent irregular menstrual cycle, or bleeding which could be any time between periods, called the intermenstrual bleeding, or associated with a white discharge per vagina or lower abdominal pain. In postmenopausal women, usually they present with the postmenopausal bleeding. As we all know, anything starts with a history examination, and usually examination may not yield much findings. A vaginal ultrasound in adolescent women, we do a transabdominal, but most indicative is a transvaginal ultrasound, which looks into the thickness of the endometrium. The gold standard will be taking the biopsy, either outpatient biopsy in the form of Pipple endometrial curettage or using a Vabra aspirator. And in fact, doing a hysteroscopy guided biopsy would be more beneficial because it can look the same time. If there is a polyp, we can do a polypectomy, and histological examination is going to be ideal. That is an endometrial biopsy, either visualizing and taking a biopsy or a blind biopsy. Management of endometrial hyperplasia through different ages. Coming to the management mainly depends on the age of the patient, whether she wants to preserve her fertility, associated comorbidities like diabetes, hypertension, or any metabolic syndrome, the symptoms, and histological type of hyperplasia based on the biopsy report. Now, through adolescent and premenopausal, this is how we are going to take the scenarios in the perimenopausal and the postmenopausal women. In premenopausal women, we do start the treatment with progestogen. Progestogen in the form of LNG-IUS, the Mirana, for 5 years. That is a first-line management. This is considered to be first-line because it causes a higher regression rate and there is a lesser relapse. And if the woman is not willing for LNG-IUS, a second-line management would be in the form of continuous progestogen therapy as medroxyprogestogen acetate 10 mg daily, which can be taken for a period of 3 to 6 months, either 10 to 20 mg from. Mainly, the continuous progestogen therapy is better than a cyclical progestogen therapy. Continuous progestogen therapy again has got a higher regression rate and a lesser relapse rate, and it has got a better bleeding profile. And we do also give women a combined oral contraceptive pill for a 6-month or a tablet norethistron if the patient wants a in-between bleed in the form of 10 to 15 mg starting from day 15 to day 28 or day 5 to day 25 when she wants to have a bleeding. How does this act? It mainly decreases the estrogen progesterone receptors, activating the enzyme dehydroxylase, which converts estradiol to its less active estrone. Activation of the progestogen receptor, which causes stromal deserialization and subsequent thinning for the endometrium. And how are we going to treat women in postmenopause with endometrial hyperplasia without atypia? That is, biopsy is mandatory before management. Progestogen therapy given continuously without break, so that she does not have any bleeding, and repeat biopsy after 6 months to have an endometrial surveillance to check whether there is a regression of the hyperplasia. If there is a persistence of the hyperplasia, repeat biopsy and a higher dose progestogen therapy in the form of medroxyprogestogen acetate 40 to 100 mg daily or a megestrol acetate 80 mg twice daily for 6 months is indicated. If women is completed family and fit for surgery, it is better to do a total hysterectomy if disease persists despite high dose progestogen. And follow-up, I need to reiterate that follow-up is endometrial aspiration every 6 months in case of postmenopausal women. Endometrial hyperplasia without atypia. Women should be counseled if they are going to just have a follow-up with progestogen, as the risk of endometrial hyperplasia without atypia progressing to cancer is less than 5% over 20 years, and most of them, they require regress spontaneously during the follow-up. Identify any risk factors which is reversible, like obesity and the use of HRT, which can be discontinued. And risk of relapse when there is a BMI more than 35 or when she is on oral progesterone, 6-monthly endometrial biopsy is highly recommended. When there is a 2 consecutive negative endometrial biopsy, the patient can be shifted to annual endometrial biopsies and further follow-up based on the biopsy results. And hysterectomy in women with endometrial hyperplasia without atypia. Progression to atypical hyperplasia occurs during follow-up. Hysterectomy is a must. There is no histological regression of hyperplasia despite 12 months treatment, and there is relapse of endometrial hyperplasia after completing progesterone therapy, or there is persistence of bleeding symptoms, or the woman declines to undergo endometrial surveillance or comply with medical treatment. In these cases, it is better to remove the uterus than to give her treatment with progestagens. So what if postmenopausal women comes to us? Postmenopausal women needing, is my slides changing? Yeah.
Yes,
So
yes,
post,
yes, Meena is
yeah,
moving.
yeah, thank you, madam. Postmenopausal women needing total hysterectomy should be offered a bilateral salpingoophorectomy. For premenopausal women, decision to remove the ovary should be individualized. However, bilateral salpingectomy should be considered to reduce the risk of ovarian malignancy later. As we all know, P53 mutations called the drop metastasis or signature can drop through the fimbrial end of the fallopian tube and can result in stick cancers, that is serous tubal intraepithelial cancers. It is important to remove the salpinx or the fimbrial end of the fallopian tube in premenopausal women if you are trying to preserve the ovaries, so that we reduce the risk of ovarian malignancy later. A laparoscopic total hysterectomy is preferable to an abdominal approach as it is associated with a shorter hospital stay, less postoperative pain, and quicker recovery. As we all know, minimally invasive surgeries advantages. There is no benefit from doing an intraoperative frozen section analysis of the endometrium or routine lymphadenectomy. Endometrial ablation, highly not recommended. Complete why we are not recommending ablation? Because there is a complete and persistent endometrial destruction which cannot be ensured, and there is an intrauterine adhesion formation which may preclude future endometrial histological surveillance. So this is not recommended even if there is a atypical hyperplasia. Coming to atypical hyperplasia, we need to think of perimenopausal women, whether they have completed family or they are infertile and not completed family. And we need to know if we are going with the previous meta-analysis, what was the outcome when we give a progestogen therapy. Progestogen therapy was an effective treatment. Previously, we were talking about complex atypical hyperplasia. The study said giving progestogen, repeating a sample after 3 months. If there is a persistent disease, increase the dose and resample. And if the woman is wishing to conceive, it is always a assisted reproduction technique. Disease regression should be achieved on at least one endometrial sample before attempting to conceive. During the intermediate period, it is important to either give her a LNG IUS or a continuous progestogen therapy. Once the endometrial sample shows there is a regression and there is no atypia, the women should be subjected to assisted reproduction. Why assisted conception? Because they have got higher live birth rate and preventing of relapse. In women with endometrial hyperplasia who wish to conceive, should be referred to a fertility specialist to discuss the option for attempting conception and further assessment and appropriate treatment. By doing assisted conception, we are actually having a higher live birth rate and higher implantation rate as well. Coming to premenopausal women who have completed family, it is important to subject them to total hysterectomy with bilateral salpingectomy with or without oophorectomy. As already mentioned, in premenopausal women with infertility, not completed family, it is better to go for high dose progestogen therapy until complete resolution with repeat endometrial biopsy every 3 months. Hysterectomy, if there is no resolution with progestogen therapy, hysterectomy should be a extrafacial hysterectomy with bilateral salpingoophorectomy and bilateral pelvic lymph node dissection. The postmenopausal women, there is a higher risk, 29% risk of progression. So it is better to do a pan hysterectomy either laparoscopically or laparotomy. Coming to salpingoophorectomy, postmenopausal women with atypical hyperplasia should be offered bilateral salpingoophorectomy together with total hysterectomy. In premenopausal women, the decision to remove the ovary should be individualized. However, bilateral salpingectomy should be considered as this may reduce the risk of future ovarian malignancy. Coming to women with atypical hyperplasia not undergoing hysterectomy, how are we going to follow up? If the hysterectomy is done, well and good. If they are not going to have a hysterectomy, it is important to repeat the endometrial biopsy as a surveillance technique. The review schedule should be individualized and be responsive to changes in a woman's clinical condition. The review interval should be 3 months until 2 consecutive negative biopsies are obtained. In asymptomatic women, that means to say there is no symptoms of abnormal uterine bleeding with the uterus and evidence of histological disease regression based upon a minimum of 2 consecutive negative endometrial biopsies. Long-term follow-up with endometrial biopsy should be every 6 to 12 months until a hysterectomy is performed. Coming to what about HRT and endometrial hyperplasia? If the woman is taking systemic estrogen, only HRT should not be used in women with the uterus. That means if she is hysterectomized, then only HRT, estrogen only HRT can be given. If she is having a uterus, the estrogen only HRT should be combined with the LNG or a continuous progestogen HRT to protect the endometrium. Vaginal bleeding is present, we have to suspect malignancy. What about endometrial hyperplasia in women on adjuvant treatment for breast cancer? So if the woman is on tamoxifen, there is an increased risk of developing endometrial hyperplasia and cancer. They should report promptly if any abnormal bleeding or discharge is there. If she is on aromatase inhibitors such as anastrozole, exemestane, and letrozole, they are not known to increase the risk of endometrial hyperplasia and cancer. So coming to the conclusion, algorithm for treatment of endometrial hyperplasia. This is from the Green Top guideline. Whenever the woman has got endometrial hyperplasia, to sum up, without atypia, always address the risk factors like HRT, if she is obese or she is having any anovulatory cycle or tamoxifen therapy. It is better to observe the women doing endometrial surveillance or start her with LNG IUS as a first line. It also acts as a contraception. It should be tried for the first 6 months. Then the next surveillance should be done. We can even give her oral progestogens in the form of second line treatment. If there is a atypical hyperplasia, total hysterectomy in the form of, just a minute. So if there is atypical hyperplasia, the treatment is total hysterectomy with or without bilateral salpingo-oophorectomy. If the woman is requiring a fertility or surgery is contraindicated, we can assess a risk, either observe or give her LNG IUS or oral progestogen. In atypical hyperplasia, the biopsy should be repeated at 3 months, and endometrial hyperplasia, if it is present, it is at 6 months. This is the take-home message. 3 months for atypical hyperplasia, and endometrial hyperplasia without atypia, the surveillance is 6 months. Now, we need to find out after the biopsy whether the woman is having regression, persistence, or progression. That is RPP. What does that mean? Regression is the sample is non-hyperplastic or non-malignant endometrial sample or non-diagnostic endometrial sample from an appropriately placed endometrial sampling device. What is persistence? There is no regression or progression of initial endometrial hyperplasia subtype after 3 or more months. That is, it is persisting. Progressing is development of atypical hyperplasia or endometrial cancer, or that is what? The progression is the endometrial hyperplasia can progress to atypical hyperplasia or a endometrial cancer. What is relapse? Relapse is recurrence of endometrial hyperplasia or atypical hyperplasia after 1 or more negative endometrial biopsy result. What are we going to do? So total hysterectomy is indicated whenever the adverse effects associated with medical treatment, concerns over compliance with treatment or follow-up, or patient prefers. There is a high level of anxiety thinking whether she can progress to endometrial cancer. Now, what are we going to do when there is a regression? So the disease is regressed. We can review the treatment. We can continue LNG IUS for another period of 5 years. So from 6 months, we can shift to 5 years. oral progestogen can be stopped after 6 months and can be shifted to LNG-IUS. Total hysterectomy with or without bilateral salpingo-oophorectomy if there is ongoing abnormal uterine bleeding. Arrange for follow-up. If the endometrial hyperplasia BMI is less than 35, 2 consecutive negative endometrial biopsy at 6-month interval, then discharge from follow-up. If the BMI is more than or equal to 35 or treated with oral progestogens, then more than or 2 consecutive negative endometrial biopsy at 6-month interval is there, then we have to follow up these women with annual endometrial biopsy and review. If the woman goes for atypical hyperplasia, then we have to shift her from 2 consecutive negative endometrial biopsy at 3-month interval, then thereafter with 6 to 12-month endometrial biopsy. If there is a relapse, go for total hysterectomy with bilateral salpingo-oophorectomy. If the woman has persistence of the disease, we have to review the treatment. If there is endometrial hyperplasia, start medical treatment if the patient's observation is failed. Advise total hysterectomy with bilateral salpingo-oophorectomy if the persistence after 12 months of medical treatment. If she goes on for atypical hyperplasia, we go for total hysterectomy with bilateral salpingo-oophorectomy. If there is a progression, then obviously we have to do a total hysterectomy with bilateral salpingo-oophorectomy. Endometrial cancer, we have to manage according to the cancer guidelines. Arrange for follow-up. If there is no endometrial cancer, review at 6 weeks and discharge. Endometrial cancer, we have to go for endometrial cancer management. Thank you for the patient listening. So there is a question in the chat box. Dr. Sudha Kulandai Madam has asked, how do we see for endometrial thickness with LNG IUS in situ? So with LNG IUS in situ, we generally go and do a endometrial pipple sampling, placing the pipple curette anteriorly without disturbing the LNG IUS. No need to remove the LNG IUS. Just insert the pipple curette anteriorly and posteriorly, take the pipple biopsy and evaluate. Based on the biopsy report, we can decide whether we can continue LNG IUS or shift her over to total hysterectomy with bilateral salpingo-oophorectomy. No more questions in the chat box, madam. Thank you, Jairani madam, TNFOG team, for having given this wonderful opportunity to me, a speaker in this event, madam.
Thank you, Meena. Thank you for accepting our invite. Madam Deepali,
Thank
madam.
you, madam.
Chairpersons, if you are there.
Thank you, Meena ma'am.
Thank you, chairpersons. Thank you, Deepali madam.
Yes, this is Dr. Suhasini. Please.
Suhasini is there, yeah.
Your
Dr.
comment.
Suhasini, you
Dr.
can conclude.
Suhasini is the president of Pusat Society.
Yeah,
Yes,
yeah, yeah.
Yes.
Madam, your words. Suhasini, madam.
Yes, ma'am. This is a difficult topic covered very well, Dr. Meena ma'am. Thank you very much.
Thank you, madam.
Thank you, chairpersons. Thank you for your wonderful sharing of this session. We move on to the next session. Aruna, if you're there, please introduce. Aruna?
Can I'm there.
Yeah, Monica.
Yeah, Monica is there.
Yes,
Yeah, please, Monica.
Yes, ma'am. Thank you, Meena ma'am, for a very wonderful talk. It has covered almost all the aspects, and I thank all the chairpersons for chairing the session. We move forward to the panel discussion. We have our first chairperson, Dr. Suvarna Bhople madam. She's the managing director of Sri Sai Hospital at Akola. She's the PSC committee in charge of the Akola OBGYN Society, the cultural and clinical secretary of Akola. She has also received the PSC Champion Awards from the AMOGS. We welcome you, ma'am. Our next chairperson is Dr. Ankush Ajmera, sir. He's a consultant and an endoscopic surgeon, assistant professor at Ajmera Women's Hospital and Endoscopy Center. We welcome you, sir. He's currently the treasurer of Akola OBGYN Society, ma'am. We also have Dr. Punkai Arul Prakash. She is in government service with the Family Welfare Achievement Award from the collector. She's the president of the Toothukudi branch of the Foxy Society, the former president of the Toothukudi branch of IMA, and she's received a Lifetime Achievement Award from various associations. We welcome you, ma'am. And Dr. Suhasini, ma'am, she is the director of Varat Netralaya and Maternity Home at Pusat, and she's in private practice since last 20 years. She's currently the president of the Pusat OBGY Society. We welcome you, ma'am. Ma'am, we request all the chairpersons to introduce our moderator for today, Dr. Sneha Bhuyar, madam, followed by the panel. Suhasini, introduce Dr. Sneha, ma'am. Ma'am, you need to unmute yourself. Suhasini, ma'am. Yes, ma'am.
Thank you for the opportunity. I want to introduce Dr. Sneha Bhuyar, ma'am. She is having 29 years of experience in this field of teaching, and she has done MBBS and MD both from BJMC and Sassoon Hospital, Pune. She is a National Individual Award FOXY 2008 for outstanding work in the rural obstetrics. Dr. Anandibai Joshi Award by Government of Maharashtra. She was FOXY President. She received FOXY President Award for Public Awareness in 2018 and FOXY President Appreciation Award for Exemplary Work in Cancer in 2019 and International MS Signature Award for Phenomenal Leadership in 2020, Lokmat Healthcare Excellent Award in 2020, Asia GC Award for Leadership in Healthcare 2021 and Champion of FOXY 2021. More than 300 talks in state, national, and international conferences, 25 articles, chapters in national publications, and peer review of JOBI. She was organizing chairperson Criticare Nagpur in 2018, and she was chairperson Breast Committee in FOXY in 2019 to 21, and founder president of 2017-19. I welcome Dr. Sneha Bhuyar, ma'am.
Thank you, my dear Suhasini. Thank you so much. I think that's a old CV. Do we have our, yeah, you can introduce Dr. Vinita Singh. I hope Vinita is there. Okay. Yes, go ahead. Monica?
Dr. Vinita,
yeah.
Dr. Vinita Singh, ma'am. She is Associate Professor, Department of OBGY in Patna, Consultant Care Hospital and IVF Center. At present, holding post of President Patna OBGY Society, and she has held various posts as FOXY ICOG Governing Council member, YTP Committee Chairperson FOXY in 2017 to 19, Joint Secretary, Clinical Secretary, Treasurer, Vice President, Executive Committee, member of Safe Motherhood Committee, Quiz Committee, and Practical Obstetric Committee of FOXY. Business Secretary of Patna Journal of Medicine and East Zone Coordinator, MTP Committee, FOXY.
Yeah, I think thank you so much, Dr. Suhasini, for your kind and generous introduction. I think quickly introduce our panelist, Dr. Gargi Bahekar, who is having her qualification as MBBS MS, DNB, and consultant at Super Speciality Hospital Bahekars at Gondia. And she also works as an assistant professor GMC Gondia. Next. Welcome, Dr. Gargi. Welcome, Dr. Varsha Deshmukh, who is at present the secretary of the Pusat Society and practicing gynecologist since 19 years. She's the director of Ayush Hospital, Pusat. Welcome, dear Varsha. Next. Dr. Pranita Revanwar, who is also a practicing obstetrician in Pusat, director of Annapurna Hospital and Maternity Nursing Home, and she's the ex-medical officer in District Women's Hospital, Amravati. Yes, Next. Dr. Shefali Jain, the consultant and head of departments of Obsgyne BJ Hospital and Research Institute Private Limited, Ganesh Nagar, Gondia, and she's the president of Gondia Society. Dr. Anita Tamarai Selvi, professor of Obsgyne, Government of Dharmapuri Medical College, Dharmapuri, and president of the...
Good evening, ma'am. Thank you, ma'am.
Good evening, and welcome, Dr. Anita. Dr. Uma Brinda, who is the secretary of Tanjore Society, and nice talking to you, Dr. Uma Brinda. Looking forward to meet you personally at your own society. Welcome. Do we have Dr. Uma Brinda joined? No. Next, Dr. T. Radhika Gauri. Yes, she's from Madras Medical College, Chennai, having 10 years of NHS UK experience as registrar, FMS World Laparoscopy Centers. Of course, she's got a clinical experience of 20 years. Welcome, dear.
Thank you.
Next, Dr. Manon Mani, the immediate past president of Coimbatore Society, and of course, president of board of faculties of Obsgyne in Tamil Nadu, MGR Medical College University, National Board of Examination Medical Sciences, appointed assessor, and of course, yes, so many accolades to her credit. Welcome, Dr. Manon Mani. Dr. Shanta Vibala, Associate Professor.
Thank you, ma'am.
Yes, good evening, my dear. Associate Professor, Department of Obsgyne, Government Tenny Medical College Hospital, and lots of achievements and publications to her credit. Let us welcome everybody. Yes, we have Dr. Gomati as well, currently the Associate Professor of Madha Medical College, Kundathur, formerly assistant professor, and of course, we welcome you, Dr. Gomati, for this panel discussion. Can I share my screen? Yeah. So, oh God, where is that? Let me, just give me a moment. I think the... So I hope all of you can see my screen. I'm just making it full screen. Yes. So very good evening to all of you, dear friends. I'm sure, see, all of this is a very common picture of labor room. All of you feel that, yes, she's going to deliver vaginally normally and you all will be relaxed. But in no matter of time, she collapses and you may have to go ahead with all these discussions. So once again, I welcome you all. This maternal collapse or near miss is a very, very important aspect to be discussed. Friends, we have been all the time talking about maternal mortality rates. So rates and ratios and numbers and figures. So these are not only numbers and figures, these are women who have their faces, and we obstetricians have seen them in the phases of their agony, distress, and despair. So these continue to haunt our dreams. That is how it has been expressed by the past FIGO president, Dr. Mohammad Fatala. And similarly, Dr. Ian Donald has also expressed in a similar way that looking back over along the clinical times, one tends to forget the failures and just take it for granted the success. But it's the failure that stands out like a killer, reminding you, the person who has faced, and of course, a warning for others. So friends, life is always a teacher, and you don't know which case, how it will present and how you have to tackle. So just keep on learning. I'm going to skip some of the theoretical aspects here. Never stop learning, because life never stops teaching you. So with this, let's start with the first case, case scenario. So this is actually a second gravida who has got previous one sees her last childbirth only 1.5 years back. And she comes to you with 7 days overdue. Her urine test is positive. So naturally, she doesn't want to continue this pregnancy. You offer her the option. She opts for medical abortion. So you prescribe her the medical abortion pills. So you guide her that, if at all she has any problem, she can come back, and you have advised her to come for follow-up after 7 days. So one evening, late night, maybe around 11 p.m., the relatives bring her in a collapse state from home. So when you examine, you find that her pulse rate is 132, blood pressure is only 70 millimeter of mercury, and profound pallor she has got. So, Dr. Gargi, what is your diagnosis? Will you investigate and manage this patient?
Yes, I would like to also increase my examination to a per abdomen and a per vaginal examination to check if there is distension of abdomen, any guarding tenderness. And along with that, I would like to check a PV examination to see whether the os is open, closed, what is the size of the uterus, whether there's any adnexal mass or any adnexal tenderness, fullness in the fornices. So if there is no bleeding, os is closed, uterus is normal size, and patient is in shock, the first diagnosis that would come to my mind is a ruptured ectopic pregnancy.
Right.
And if the os, yes, so that would be the first thing that would come to my mind.
What else? Anything else?
And
so you mean to say ruptured tubal ectopic
a
pregnancy?
ruptured tubal ectopic. Secondly, also because she's had a C-section and the pregnancy is just been say 1.5 years back, there can be chances of a scar ectopic as well.
Yes.
And yes.
So how will you manage now? Now that you have the diagnosis, differential diagnosis, how will you manage it?
Yes, so initially the management would begin with the first resuscitation of this patient. So securing 2 large bore intracath, replacing the volume, that means start with a crystalloid and send for urgent investigations, which would include a complete blood count with a hemoglobin, a platelet count, a WBC count, and to confirm my diagnosis and emergency ultrasound.
So
To
you
look
belong
for.
to a small
Yes.
place. So whether you have the ultrasonologist available at late nights, whether you have yourself.
Yes, we do have an ultrasound machine in the hospital. So perform a transvaginal ultrasound to look for the uterus, the gestational sac, or any adnexal mass, and then looking at the whole scenario and the clinical picture, then arrange for blood products. And then if it is an ectopic pregnancy or ruptured ectopic, then we have to go in for the subsequent
Surgical
management.
procedure. So whether you would like to go ahead for laparoscopy or open laparotomy.
After arranging blood products, we take a high risk consent of the patient, explaining the condition of the patient. And in a place like Gondia, maybe at that time I may not be very skilled in doing a very quick laparoscopy. So better than wasting time, it would always be better to go in for an emergency laparotomy and go ahead with the surgery, because it's a life-saving procedure. As soon as you stop the bleeding, the patient is going to recover immediately.
Right. So the message from this operative, we talk about only the surgical procedure. It's not always heroic to go ahead with laparoscopy. If you have, or if you yourself is a skilled laparoscopic surgeon who can quickly put in a trocar and quickly suck out all the blood and catch hold of the bleeding point, that is well and good. But as you very rightly said, if you are not skilled enough, if you are not comfortable with the procedure, it's always better to open up fast and catch hold of the bleeding point. So that is laparotomy. Whether you would like to go ahead with the salpingectomy or you would like to conserve the tube.
If the tube is totally ruptured and damaged, then chances of salvaging the tube are very less, and I may go ahead with a salpingectomy. However, if the tube is not very bad, maybe, but since she has one living issue, I may go ahead with a salpingectomy instead of a conservative
But she
surgery.
has also other tube also.
Other tube is also there, and you have to examine the other tube whenever you do any any ectopic patient. You must always examine the other tube.
Yes, that is the right message. And yes, that is what we say, because you are suspecting or your diagnosis is ruptured ectopic. Once you confirm that the tube is ruptured, there's no point in conserving it, because the damaged tube, whatever way you conserve, may also, lead to recurrent ectopic pregnancy. So here you have to go ahead with the salpingectomy, the procedure. So So naturally, the patient needs a very, very urgent management. As you very rightly said, that you have to arrange everything and take her for surgery. No more waiting. Okay. So that is how, simple procedure, simple, early pregnancy, medical abortion. The patient has landed up into this complication. She has come to you in a collapse state. So what message you would like to give it to from this case? What are the learning points?
Yes, so we must remember that whenever patient comes for medical abortion, even though it's not anywhere mentioned that it's a mandatory thing, but I feel we must always confirm the presence of the gestational intrauterine sac and only then prescribe the
Right.
medical abortion drugs, because it's an
Hello?
unsupervised procedure and patient can land up in such complications. And
Correct.
hello.
Yes. Yes.
Yes.
Go
So,
ahead.
and also proper counseling of the patient is must, that when she should follow up and tell her the warning signs and symptoms. Because even in a case with intrauterine pregnancy and who has taken medical abortion, sometimes they do have very, very heavy bleeding, and patient go into, they collapse at home with severe pain or with severe bleeding, and patients are brought in a state of shock. And
Yes.
hence, telling the warning symptoms to the patient is also important.
Perfect. So the take-home message from this case is, even if it is not mandatory to go for ultrasonography, it is recommended for the safety of the patient and yourself. Okay, that is the first point. Secondly, you have to take an informed written consent from these women. You explain them what is the procedure and what warning signs, as you have rightly pointed out. So if at all she doesn't bleed and gets only spotting, or she gets fainting attacks, that is very classical. Or whenever you have a tubal distension or contractions, you have very classic fainting attacks. So if the patient notices this, she should come to the hospital immediately, and then of course you have to manage accordingly. And then of course, because she is in a collapse state, you have to go for surgical procedure immediately as soon as you do what is called as aggressive resuscitation of this patient. So very well said, Dr. Gagi. Thank you so much. We go ahead with the second case now. Here we have this 36-year-old, lady who was treated for infertility. She conceived with IUI. Her husband is working in Dubai and she stays in a village, but because it's a precious pregnancy, she's coming to you regularly. So at around 24 weeks, she asked you, is everything normal, doctor? You said yes, and she knows she's lost to follow. Suddenly at 34 weeks, in a village, she comes to the PHC with complaints of pedal edema and upper abdominal pain. When the medical officer saw the blood pressure, it was 176 by 116, and fetal growth was apparently normal, but urine proteinuria was positive, and her blood pressure was very high. So the medical officer gave only tablet nifedipine retard. Okay, and she was explained that she should go for admission at a higher center. But unfortunately, this lady did not go for admission on the same day. After 2 days, she reported to the higher center, where in spite of this tablet nifedipine retard, her BP was 168 by 110, that is severe hypertension. So they just added tablet labetalol and started with magnesium sulfate. So at sub-district hospital, they had the anesthetic, so they immediately went for cesarean section. They delivered the 1.8 kg live female child. And post-operatively, this lady's blood pressure, in spite of all these two antihypertensive, remained between 140 to 180 systolic, 100 to 110 diastolic. Suddenly, after 20 hours, she had severe cough, breathlessness, restlessness, and her pulse rate was 115, BP was 220 by 118, oxygen saturation dropped down to 70%, her chest was full of wheeze and breath sound. So, Dr. Varsha, what is your differential diagnosis and how would you manage this patient?
Madam, as patient is higher blood pressure, that is PIH patient, and after 20 hours of cesarean section, she develops sudden severe cough, breathlessness and restless. Her
Right.
pulse is tachycardia, she is tachycardic. BP is higher side 210 by 118. Oxygen saturation is dropping and chest is full of wheeze. So my first probable diagnosis goes to pulmonary edema.
Correct. Any other diagnosis you have in your mind?
Internal cardiac disease or fluid overload.
Peripartum cardiomyopathy.
Or fluid overload or infection or septicemia.
Yes, one more, pulmonary embolism.
Yeah,
Yes.
rare is pulmonary embolism.
Okay, so how would you manage this?
First of all, I call for help, anesthetist, physician, propped up position, start O2, and antihypertensive drugs, IVA.
Yes, which one?
Then I will give Lasix.
Lasix. How much Lasix you will give? Lasix how much? Because we obstetricians give Lasix like pediatrics, pediatricians.
No. 2 to 4 ampoules we can give.
At least 40, no.
40 ml.
Lasix ampule is large
40 ml.
40 ml. Yes, 40 milligram Lasix. Okay, 4 ml ampule usually you have Lasix. So that is 40 mg. Okay. 40 mg you should give as a bolus because you are suspecting pulmonary edema. So what is pulmonary edema? It is actually, collection of the fluid in the interstitial and even the alveoli. Normally, which are the compressible ones, they fail to, the compliance is reduced. They become like solid. And that is why there is a ventilation perfusion mismatch and increase the workload for breathing. So that is why you have to give Lasix so that fluid is pulled in the intravascular spaces and excreted out. That is what is the role of loop diuretic. Okay, so as you rightly said that you have to give her antihypertensive intravenously and Lasix. So 40 mg. What antihypertensives for this patient will be ideal?
IV labetalol.
IV labetalol.
Ideal. What will be the ideal one? Actually, if you have
NTG.
edema, yes. Somebody said something?
Starter on IV nitroglycerin.
Correct. Perfect. Because, as an obstetrician, because now we are well versed using labetalol. So our tendency is to give, because it's a very severe hypertension. So our tendency is to give labetalol, but given a choice, if you have already called or invited your anesthetist or physician or intensivist, NTG infusion is the best antihypertensive for this. Okay. For pulmonary edema especially, because otherwise labetalol has, if you remember the criteria for labetalol, it usually reduces the rate, the pumping power also. Okay, so it has got a negative chronotropic effect. Okay, and that's a very reason for cardiac patients we should prefer the NTG infusion. So you have checked that the patient is breathing properly, her airway is good, her circulation is maintained well. Now, if it is not maintained, then you have to give dopamine also because now she's collapsed already. But if you're not sure about your diagnosis, you will do all the investigation. So what investigations you want to send for her or do for her?
Bedside investigation of complete blood count, LFT, KFT, X-ray chest, and 2D echo for true cardiac abnormalities.
Yes, and in some cases, you should also do the cardiac enzymes. Nowadays, the myocardial infarction and other cardiac illnesses are also presenting at a younger age, right? And maybe our obstetric population is becoming more and more, they belong to the elderly groups. That is why. And she is already, treated for infertility, precious pregnancy. So her age is, that she's an elderly gravida, right? So all the investigations you have done and you have now come to the diagnosis that yes, it is definitely pulmonary edema. And you are trying to, but by the time you are trying to do that, she is suddenly progressing very fast. So suddenly she develops cardiac arrest. Now, how will you resuscitate her? She was given propped up position. She was given Lasix. She was given labetalol. She was given labetalol. Okay, and oxygen. So
yes, anesthetist call, mask oxygen started.
So, but then she still went into cardiac arrest. Now, how do you revive her?
Patient is shifted to ICU with anesthetist.
But there at that point, by the time she was already there in ICU, patient was shifted to ICU. So how do you treat her now?
Monitor her blood pressure by giving IV antihypertensives.
Yeah. But then before that, she's into cardiac arrest, right? So you have to give her CPR.
CPR.
So what, Pranita? Where is Pranita? So
Yes,
how
yes.
how do you give CPR? How do you
With
give
bag
CPR?
and bag and mask?
Cardiopulmonary resuscitation. Bag and mask, you're giving only oxygen. Okay. But if she's not breathing, what will you do? If her heart is not pumping, then what you do?
Cardiac massage, with cardiac massage.
Yes. Yes. Anybody wants to add, Dr. Gargi?
When initially you have to call for help and activate code
They're
blue.
there already. They're
And
there.
yes, so we
Anesthetic
start with
then-
chest compressions.
Yeah.
Compressions, yes, it should be at the rate of around 100 to 120 in a minute. And if you have bag and mask along with that, then it should be 30 compressions followed by 2 ventilation.
Correct.
And you have anesthetist, everybody available. You should plan and intubate the patient.
Yes.
And if you also check for if the patient's pulse is coming back or not, and if you have to check for the rhythm on the ECG. And if the rhythm is a ventricular fibrillation or a ventricular tachycardia, then we can give her a shock of around 200 joule shock. A DC shock can be given to revive. If it's still a pulseless electrical activity, or if there is a persistent asystole, then we have to continue CPR and give the first dose of adrenaline. 1
Yes.
ampule adrenaline IV bolus, and fluid drip NS should be started. And the CPR should be continued till you get a shockable rhythm. And continue to give adrenaline, repeat again after 3 to 5 minutes if the rhythm is still not achieved. So the cycle of CPR and adrenaline would continue till you get a shockable rhythm. And as soon as you get a shockable rhythm, you deliver another shock. And if the sinus rhythm is achieved and patient's pulse is revived, then the patient can be, then the next line of management can be done. Like you do her fluids and you then assess why the patient went into arrest. If the BP is low, you start her on noradrenaline infusion.
Yeah, or maybe whatever dopamine.
Whatever is the reason.
Yes. So you have said the very vital point. For us obstetrician, this is very, very important because having a cardiac arrest is the worst thing you can have, because nowadays you must have heard that some patients, you feel that it is myocardial infarction, but it is not. That is only cardiac standstill, and you have to be well versed with cardiopulmonary resuscitation even when you are not a medico. So for us being a medico, we have no excuse. As you rightly said, how many cardiac thumbs you want to give, and how many
100 to 120 in a minute.
Yeah.
Compressing around 5 to 6 centimeters at the lower end of the
That
sternum.
is what we have to say. That it should go at least 5 centimeter down. 5 centimeter down. The compression should be 5 centimeter. Okay. So then only it becomes effective. It's at the lower end of the sternum with 2 hands, and at least 5 centimeter you should be able to depress. 100 to 120 per minute, that fast it should be, and then you give 2 ventilation or the breathing. Okay, so 2 breaths you have to give, and then as you have rightly said that you have to add adrenaline if you are not getting the rhythm. But then you are using the shocks again after an interval of how many minutes? You tell me. The first shock you give, yes.
The first shock we've given, but she's still not achieved the sinus rhythm. So we continue CPR. We give adrenaline again after 5 minutes. And then the next shock can be given after that.
Yes.
Around.
So that is the most important part. CPR is the one which we must. Okay, because now here in this case you have the anesthetist and physician with you. That is why it's all the responsibility of theirs. But sometimes it can happen that before you call them, you have to manage as an emergency, as a first aid at least. Okay, so CPR is a first aid treatment. Okay, it's a first aid. Even non-medico should know it. So that is why I'm giving so much stress on that. Okay, so we have, yes.
There should be a tilt actually during the CPR of any.
This patient is a post-Ellis.
Hello. Yes, Priya. Who?
Sorry, Radhika here.
Radhika, yes.
A small tilt actually. We should give a wedge before giving a CPR to a pregnant woman.
Yes.
But this
That we should always remember.
Yes, definitely.
this
What tips you
patient is
want to give?
postpartum.
To prevent aorta cable compression.
Yes. But here in this case, she's already operated. It's not a gravid uterus.
Okay. All
Yeah,
right.
it's not a gravid uterus. She's already delivered, right? Cesarean section 20 hours later. So
Okay.
you're
Yeah.
correct.
Yeah.
When she is pregnant with a gravid uterus, definitely you have to give a left lateral tilt. Okay. And once you deliver the baby, CPR becomes more easy and more, effective. Okay. So that is how it is. So all of us know why, simple, patient who has conceived happily and she was coming to you regularly, landed up into a catastrophe. Can somebody talk about the prevention? I think Dr. Radhika, I will ask you only. Whether this catastrophe could have been prevented if you, go retrospective to the patient's history right from early pregnancy?
Yes, ma'am, sure. We should have screened her from the first with the history. With history, we can ask whether she has any risk factors like she's a priming, it's a risk factor, any other lupus or any autoimmune disorders or previous history of PIH or any other.
My dear, she is a case of primary infertility. You're right that she
Yeah,
should
that
be
itself is
screened.
yes, that itself is the most important risk factor. So
She is the elderly gravida, that is the first risk factor. She is treated with IUI, infertility. Okay, that's the second one. And then she should have been screened during early pregnancy with NT scan and the uterine artery percutaneity index. And if available, the PLGF and SFLT, even those. Okay? Okay. Yeah. And then
we can monitor every month or every 4 weeks. We
so
should have
at this point, once again, if at all you have to calculate the very simple Justosis score. If at all you have these high risk factors from the maternal characteristic, you should have started her on aspirin 150 milligram because she is high risk, okay, and high dose calcium and vitamin D. So preventive measures. So prediction, that is screening, prevention by low dose aspirin and high dose calcium. Okay.
And then pressure fall. We should keep an eye. If it doesn't fall, the blood pressure should usually fall during the mid trimester. And if it does not, obviously we should be cautious and keep calling her back every 3 weeks or 2 weeks. And also we should ask the village health nurse or whoever the nearest hospital she should visit and monitor her blood pressure.
Yeah.
We have to start her on antihypertensives if it is the blood pressure going up.
And what about her first visit at PSC when a BP was 176 by 116? Whether it was right treatment?
Yes, they should have immediately referred, but before that they could have given labetalol, even in IV labetalol also, or even if it had been retard as they have given, it is okay. But I think
no, not okay, not okay, my dear. See, she's a case of severe hypertension when she was diagnosed, right?
Yeah, IV labetalol. They should have given the loading and also Maxilf.
But PHC you cannot give. PHC you cannot give. So what is the second option for severe hypertension?
Yeah, the second option is
Vasini. What is the second option for severe hypertension? Come on, we people are using it regularly. Antihypertensive.
Nifedipine tablet.
Yes, no, not retard, not retard. Retard itself tells you it's a slow acting. It says capsule nifedipine, the orange color capsule, 10 milligram. Okay. The onset of action is within 5 minutes and the peak action is 30 minutes and the duration of action is 6 hours. Okay. Dr. Gargi, you agree with us?
Yes, ma'am.
For severe hypertension, you have two antihypertensives to be, the one is IV labetalol. Not many people are well versed. You may not have the physician with you. So capsule nifedipine 10 milligram, that is the best option, which is very, very safe and effective, provided you give it orally, not sublingually. Okay,
Yes.
oral capsule nifedipine is a very, very effective way. So that they should have given, even if at PHC they had given capsule nifedipine, her BP could have controlled. Even when it comes to a sub-district hospital, the next higher level, they had given only tablet labetalol. There again, that was a mistake. Okay, so a simple scape that was, spoiled at every level. Okay, now when they decided for cesarean section, what precautions they should have taken? Tell me. Preload, preload we give the fast IV fluids we give before giving the spinal anesthesia. So that should have
Restrict
been
IV fluids.
avoided. Yes, that should have been avoided for this case especially. Secondly, you should never give methergine. Maybe at lower center they may have given methergine. That increases the venous return during third stage and immediate post-op. That also can lead to this condition. And then of course once the baby is out, they should have given Lasix intravenously. That could have saved her going into pulmonary edema, right? And when you have such a high risk patient, this patient needs to be monitored for at least 72 hours, very closely. So you should have this patient into either obstetric SDU, ICU, and maybe if post-op you cannot manage, they should have shifted the patient to the higher center at that point of time at least, right? So
Fluid management also, ma'am. The amount of fluid per hour, it has
yes,
to be slow,
yes,
and that has to be monitored. And as early as possible, start her on oral.
perfect, perfect. Start her on oral, start ambulating her because she's
And
also
because of her age, also we should have also seen her cardiac status.
yes.
Probably that also can lead on to. We should not forget that also. Pulmonary edema. Whenever a patient goes for pulmonary edema, cardiac cause also should be kept in mind, ma'am.
Yes, in fact, he should have evaluated as you do in Tamil Nadu. No? Every pregnant lady you do echo, 2D
Yes,
echo.
ma'am.
Yeah, so this
Yes.
lady was an ideal candidate to be evaluated by 2D echo even before, posting her for cesarean section, at least that time. Okay, so
We do it at our center as well.
yes, so her
Urine output also observed, madam.
yeah, that too monitoring it comes
Monitoring.
yeah, monitoring for first 72 hours. Okay, because
So
one
actually,
after
they'll have again a rebound hypertension around 3 to 7 days after delivery. So we have to be very careful till even 10 days. There is a fluid shift, and there will be again increase in BP between day 3 and day 10 also. So we should be cautious when we are dealing such patients.
yes. So every patient who has developed hypertension, you need not relax. Previously used to say once she is delivered, then things are, going to revert. No, postpartum gestosis, postpartum eclampsia, these are the terminologies now, increasing rapidly. Okay.
That is the most important cause of mortality these days, actually, postpartum.
Yes. So prediction, prevention,
Yes.
early detection, and prompt treatment. Of course, post-operative follow-up. Every stage,
And
very vigilant.
venous thromboembolism risk is also there, ma'am. So
Yes.
thromboprophylaxis also has to be given.
Right. So we quickly go to the third case now. Dr. Shefali Jain.
Yes, ma'am.
Yes. So we come to you now. This is a patient, 20-year-old young primary gravida. She comes to you 9 months amenorrhea. She was admitted in the afternoon at a small nursing home, nearby nursing home. She was there in labor for almost 8 hours. She was having very strong contractions. And then, they saw that she's not progressing. So they have to take her for cesarean section. When the staff nurse tried to catheterize her, there's absolutely zero urine. Okay, so they retrospectively inquired. So she has not passed urine for almost 12 hours. Okay, 4-5 hours before admission also. So she was having zero output. Now they got scared, so they referred this patient to tertiary care center. When the patient comes to the tertiary care center with severe pain in abdomen, BP 110/70, pulse rate is 110, that is tachycardia. She's got very severe uterine contractions with strong intensity, no relaxation in between. Fetal heart is 100 to 120 per minute, and cervix is 3 centimeter dilated, membrane substance, station 0, altered brownish colored bleeding, she has. So what is your diagnosis, Shefali, clinically?
When the patient comes to us, madam, then already the patient is about 12 hours of the labor pains.
Yes.
So first alarming sign is the 12 hours of the labor pains, because once the patient is in active labor, she should either see the sunrise or the sunset. It is the indicating mark, actually what we see. So first thing is the prolonged labor. Then she is
what you are saying is she should not see the sunshine again.
both
Yes,
no,
for 24
both
hours.
sunrise and sunset she should not see.
Yeah.
Then she is having, second thing is that she is having tetanic contractions.
Yeah.
The third is that she is having tachycardia.
Mm-hmm.
Then fetal heart is she is having bradycardia.
Yeah, yeah.
So all these things are
and altered bleeding.
Altered bleeding, and then she is having anuria, complete anuria.
Right.
So
what
all
is your
this is,
diagnosis?
and this is going in favor of concealed abruptio placentae. And she is
Abruptio placentae with
anuria, with anuria, and because her platelets are on the lower side, the coagulation profile
No,
is
we are
also
not coming to that. We are still in the clinical phase. She's having abruptio placentae. You said concealed abruptio because not much of bleeding. That is one. I agree with you. She's having anuria. That is two. I agree with you. She's having fetal distress.
Yes, bradycardia that I told them.
Okay, perfect. So now when we do her investigation, her hemoglobin is 8 grams, platelet count is 1 lakh, PT-INR is 2 and APTT is prolonged. Her fibrinogen is only 150, it should be normally 400 milligram percent,
Yes.
and FTP, fibrinogen degradation products are present. Now you tell me what is your diagnosis?
So, this is abruptio placenta grade 3. Because she is having altered renal function, that is anuria, with coagulation profile is altered, and as well as the fetal
so she's going into DIC. She's going into DIC.
Yes, she is progressing to DIC, but she is not actually in DIC at present.
Yeah, going to DIC. Okay.
But not at present. But the renal compromise has already started. And fibrinogen is also on the lowest side. What we say is 150.
Right. Yes.
And FDP is also present here.
Yeah. So
that
once
is also
you have
very
FDP, fibrinogen degradation product, that tells you that she is already into early DIC.
Yes, early DIC.
Absent, correct? So this is your complete diagnosis. Okay? So you have to manage all these aspects. You tell me, you have got abruptio placentae and the fetal distress. So you want to save the baby. Whether you will take her for immediately cesarean section. Take her for cesarean section immediately, or how?
In such cases, we have to simultaneously manage the labor as well as the renal function as well as the coagulation functions. Simultaneously, we have to manage all the three things.
Yeah.
And for the labor, because she is having tetanic contractions and bradycardia, she should be taken for the LSCS immediately, but simultaneously her 2 white bore IV lines should be secured, and blood should be simultaneously sent for the cross matching, and all the investigations should be sent for the coagulation profile, and immediately we should have arranged all the blood and blood products.
Yeah, right.
And
so that's a message, very, very clear, that you have to manage everything simultaneously, act very promptly, arrange everything, start giving the blood components, whatever is necessary, and go for operative procedure. And of course, this lady who has had abruptio plus APH is very, very prone for PPH. For many reasons, because you have coagulopathy, you have, prolonged labor, and you have the non-contracting uterus because of the cuvular uterus, it must be there. Okay, so because...
And simultaneously, she can at any time go in for the intrauterine death also, because these patients are very...
that is why we have to act very fast. So there is a request from the platform, we have to hurry up. And Dr. Anita has already discussed some issues, but now we go to Dr. Manonmani. Manonmani, madam, this is a case for you. You have this 32-year-old para 1 previous cesarean section, male child only 1.5 years ago, And during the 6th month of pregnancy, she comes to you for the first time because her husband gets transferred to your place. Okay, so she comes
Okay.
to you with history of bleeding PV. And when you do examine, when you ask her further history, there is a history of some spotting in the early pregnancy, and the early pregnancy ultrasound also shows low-lying placenta. When you do ultrasound at your place, you find that the placenta, she's got placenta previa, there is absent RP leg, and the anomaly scan is normal. Okay, so this lady at 30 weeks, she starts bleeding profusely at home, and when you are doing her investigation, she collapses in front of you. So what is your diagnosis, madam, and how will you manage this patient?
Yeah, she's a case of previous cesarean section with a 1-year-old child, and the previous ultrasound showing low-lying placenta. At 26 weeks also, it was a placenta previa with absent RP leg. So probably it is a adherent placenta, is a placenta accreta syndrome. So it could be a increta or could be a percreta. So
Right.
at 30 weeks, she has bled and she has collapsed. Then we have to intervene immediately, resuscitate her, as already been discussed, with a double bore green Venflon, and take a blood for cross matching and order for massive blood transfusion because she's bleeding and collapse. Probably she's
Yes,
having
you have to
increased.
initiate.
Yeah, we have to
massive-
initiate a massive blood transfusion protocols, and
Yeah.
immediately you have to take her up for laparotomy and proceed. Probably or cesarean. The baby, you have to see whether the baby is viable. Anyhow, it is 30 weeks. But then when she is bleeding and collapse, there is a possibility that baby is also
Yes,
have
compromise.
gone in for distress or could be IUD. But anyhow, to save the mother, we
Yeah.
have to go immediate rush and resuscitation, and simultaneously you have to do surgical intervention.
Yeah, you're right on your part, but then, Dr. Manonmani, the relatives, what do you talk to them? Because, they are
We have to
surprised.
counsel them. Yeah.
Yeah.
We have to counsel them. One is it is a preterm baby. So anyhow, simultaneously resuscitation, and we can go for steroid as well as magnesium sulfate. By the time we take her for cesarean, whatever the drug is going to act, it will help for the
Madam,
lung
when the
maturity
patient
and
is
the
collapsed,
neurological
when the
survival.
patient is
And
collapsed, is
collapse,
there
you have
any
to
role of...
counsel them.
Yeah.
Resuscitation, counsel them, you have to go, and if needed, we may have to land up in hysterectomy also to save
Yes.
the mother. If the placenta is densely adherent, we cannot save the uterus. We have to get the consent for hysterectomy, cesarean hysterectomy also.
Perfect.
And with blood transfusion, massive
Your
transfusion.
patient says that, yes, okay, you are going ahead with the operative procedure. You are telling them that your baby will be extremely preterm, and we cannot assure you the survival and maybe the prognosis. If at all it survives, we cannot assure. You have taken the informed written consent, but the patient is resistant that, she doesn't want to go for hysterectomy. Then whether you have some uterine conservative procedures.
So some conservative triple P procedure we can remove if it is anterior placenta versus adherent in very few places, then we may go for a triple P procedure. So remove only that part of the adherent area and reconstruct the uterus. Or previously it has been said
What
that
is
you
the
leave the
triple P?
placenta.
What is a triple P?
Triple P, only the myometrium with attached placenta is
Yeah.
removed.
So
And
first
you,
P is you have to map the placental mapping.
yeah.
That is the first P. And second is pelvic devascularization. That is stepwise pelvic devascularization.
Uterine,
go ahead.
ovarian, followed by internal iliac. Yeah.
Yes. And third is patchy myometrial resection, as you said. This is what is third. And there is one more procedure that is called as, it is AMOG MG stitch, where you have to, occlude both the anterior divisions of the internal iliac artery. And then you have to make the uterus totally avascular, and then you scrape out the placenta. Okay, and if at all there is bleeding, you suture it and compress. Compression sutures you have to take it, and then this patient usually doesn't bleed when you make this type of suture called as AMOG MG stitch. This is at some centers they are very specialized and they are going ahead with this type of uterine conservative procedure. But for our patient who is collapsed and she's bleeding profusely, we have to stress on it that there is no alternative. We have to save the mother, and we should not bother about the uterus. So I think, yeah. Thank you so much, Dr. Manonmani. Yeah, it was a
Thank
nice
you.
discussion. And do we have Dr. Uma Brinda? Anybody who has not spoken wants to speak out about this? Anybody? Do we have Dr. Shilpa and anybody? The
Dr.
last
Uma is
person.
there.
Yeah,
Dr.
Uma is there?
Uma is there.
Yes, yes, ma'am.
Yeah,
Yes,
Dr.
yes,
Uma
ma'am.
is there. Dr. Uma is there.
I'm
Yes,
calling
madam.
her again and again. Where is Dr.
Yeah.
Uma?
Yes, ma'am. Yes.
Yes, hi,
Yes,
Dr.
ma'am.
Yeah, yes. Hi,
Hi,
hi.
madam.
So you just, this is the last discussion from this case and we are going to stop. Dr. Uma,
Yes,
was
ma'am.
it possible to prevent this catastrophe? If you, I mean, early pregnancy, she was diagnosed with, having warning hemorrhages. She was having low-lying placenta. So was it preventable? Whether we should have given her a stitch cervical cerclage or should we have put her on tocolytics? What is your opinion?
No, madam. There is no role for us tightening or tocolysis in placenta previa, madam.
Yes,
We
absolutely.
should be.
In fact,
We
there's
should.
a strict no.
It should be planned.
Yes.
Yes.
And what instructions? You know, this lady is having warning hemorrhages right from early pregnancy. What instructions should have given?
She should be advised not to have any sexual intercourse, not.
Yes. And she should have been hospitalized right from the beginning when she was diagnosed with, absent RP, like, and when she was diagnosed with PAS, she should have been registered with the tertiary care center itself, right?
Yes, yes, madam.
Whatever expertise you have, we are not supposed to manage in the individual small nursing homes. This is a condition which needs multidisciplinary team approach, right? Where centers, yes. Yes, please.
At any time, she should be monitored where 24 hours surgical team.
Yes. That's right. So even when we have lots of interesting cases because of lack of time, I'm going to wind up, and I'm very happy that all the panelists are very well read and everybody has contributed enormously to the discussion. Only I will talk to you the take-home message. What is practical? You know, I am a hardcore obstetrician practicing since last 33 years. The CV was old one, I think, so 33 years. So friends, every obstetric unit and every person of the obstetric team must be trained and skilled to manage the maternal collapse. As I, stressed on the CPR, cardiopulmonary resuscitation, which is very, very important as a first aid. There is no time for immediate referral, you cannot refer the patient in that critical condition. In fact, referring the patient in a critical condition is a crime. You can be sued for that. Okay, and your patient may die on the way. So referral in unsettled case may worsen the situation due to multiple issues. So the team should manage effectively then and there only. Of course, you should call for help. Definitely shout for help. You may even call your senior experienced person or your junior expert colleague. You shouldn't hesitate at all. It's ultimately the patient's life and your mental peace that is most important, and that is why we should always care for it. So wish you all a very happy litigation free practice, and I'm sure we have contributed much to our discussion. I thank all of you, especially Tamil Nadu Federation, TNFOG, and Madam Ramani Devi, Sampath Kumari, and my dear friend Jayanani. Thank you so much, Jaya. And I just take this opportunity to make a humble appeal to all of you, friends. Please do nominate free from all your societies for the post of Foxy, Vice President from West Zone. And please do share with all your society members my flyer, my vote appeal. I request maximum votes from all of you. Thank you so much, dear. Thank you so much.
Thank you, Sneha, and thank you for that wonderful, very amazing, very thrilling case presentation. It was nice hearing from all the panelists, all the dynamic people from TNFOG and from the AMOGS who have been wonderfully, amazingly talking about the emergency obstetrics, that is the maternal collapse, which is really very good presentation and very good talk. Thank you so
ma'am.
much. I thank on behalf of TNFOG and also AMOGS Emergency Obstetric Committee, I thank all the faculties here and all the panelists for their wonderful sharing of their knowledge, which is really a very good one. Now our webinar has been attended by 138 participants, and I'm very happy to hear that. And on behalf of every one of you, I thank our chief guest, Alka Madam, for joining with us and blessing us with her energetic way. And also thanks to our guest of honor, Dr. Madam Kiran sir, and also Madam Neeraj Batla Madam, Ramani Devi Madam, Sampath, everybody for encouraging us. And also very special thanks to the speakers, Dr. Chitra, Dr. Meena, and Dr. Sneha for their wonderful presentation, and very dynamic panelists from Gorgi Bahekar, Dr. Varsha, Dr. Pranita, and Dr. Shafali, and my dear TNFOG, Dr. Anita, Dr. Uma Brinda, Dr. Radhika Gauri, Dr. Mano, and Dr. Shanta Vibala and Gomati, for all sparing your time, your knowledge sharing, which is the success of this webinar. Thank you so much for everyone. And I also, to all the president and secretary, let me put a humble request to nominate me from your society for the Violence Against Women Committee, No to Violence Against Women Committee chairperson, because the nomination will be coming in the May 1st week. I would request you all to nominate me as well as Sneha Madam for the Vice President of the West Zone from your societies, and let's all give a big support to her, because she's very dynamic in her knowledge, and we should have such persons in FOXI Central Team. Thank you so much for all your participation, and thank you so much for the wonderful presentation. And all the more, I'm thankful to Shield Sahiti for giving us the nice platform, and a very special thanks to Priya for assisting us in our work, and also to all the delegates who were there right from the beginning before we started till this end, for all your support, which is really giving us more encouragement to do such webinars in futures. Thank you so much, and thank you one and all.